So the medical students usually the last 2 years, with the final 2 years, they're attending the world to gain some skills and needing your help. So you might see them. FY1 and FY2, which is the foundation year 1 and foundation year 2, which is quite equivalent to internship, which is the program in our Sudan or our Arab countries. So they have some sort of limitations. For example, they might not prescribe medication or might not see the newborn alone. So still they need your help. Specialty training, this is the doctor that joined a structured training program governed by the Royal College of Pediatrics. So as you see in the slides, they're starting from the ST1 up to ST7. So for the first 3 levels, which is ST1, ST2, and ST3, they call the SHO, which is the junior level of training. And starting from ST4 plus, they call at the registrar, which is the senior level of training. The NHS tried to change the name with the SHO to the central doctor, but still use the SHO widely in the NHS. So this might need some time to be changed to the central doctor. What is important for you when you try to apply for a job to the NHS website, you will see there is a different name for the jobs: trust doctor, clinical fellow, a central doctor. And what's quite important for you to look for this job, what is equivalent exactly to. For example, we see the first one, which is trust doctor in pediatric, and it's equivalent to ST1. So you expect yourself to work at the SHO or the junior level. Clinical fellow in pediatric and ST4 are equivalent. So you need to expect yourself to work at the registrar. I hope that's clear. Let's go to the job description of the SHO. I'll try to make it more practical. So the guys expect you to come at 9 o'clock. This is the time where the work will start. So please make sure that you have enough time to reach before 9. The handover, so all the team will gather in the handover room. This is one room, I will not to everyone. Starting from the medical student up to the consultant. And the night shift will hand over all the patient in a structure we call the SPA. And my colleague will talk about that in a minute, to the morning team. And then we'll say goodbye to the night team and hope them a nice sleep. All the team will direct it to the nurses team and have also a quick handover to know more about the logistic situation about the ward. For example, the bed status, staffing problems. If there's any patient need to be prioritized to see in the ward, or there is an incident happening during the nights, it's very useful handover. The team will start to divide themselves into 2 major groups or 3 major groups according to the number of the seniors present in the ward. There is a consultant that gets fast, and you guys the SHO will follow one of them. You start to review the patients one by one, and it's really quite important and helpful if you have just a quick chat with the primary nurse who handled the patient to give you really more update about the patient condition, what happened during the nights. And as usual, you look at the door with your seniors, go to see the parents, introduce yourself, smiling, ask about the condition, addressing the concern, and make sure that the mom or the dad, and even the patient, if he is young adult, understand what's your plan is and check understanding. Documentation, I think this is one of the major job of the SHO, proper documentations. And documentation is for yourself, for learning, and for medical legal aspect as well. And the documentation without used here in the NHS is a SPAR technique. I will talk about that in a few minutes. Another end, you need to sign yourself and your senior who is making the round with you. This is a quick example about documentation, how it looks like. You see the first line that WR, which just means that word round by Dr. X. We put the date and the time. SPAR technique. It's really helpful if you try to elaborate about the patient concern. For example, the mom concerned about the diarrhea and the patient is not improving. So you need to write that in words. And what the discussions you did to make the mom sure that she's really on the right side. This is a very important thing, so you need to write it. So again, you sign your name and sign your senior names also who do the round with you. It's really very important if you try to use the resources available in the board. For example, you have a portable computer to do the X-ray or the blood test. This will be very helpful for you instead of going to the main desk and see the blood and X-ray. Try to be oriented about the things of the walls. where the places of things, if you're needing the otoscope and take the process, the present is in some couples, so please try to be oriented about that. Another thing is there is a level one access. I've just heard about that maybe a few days back from one of my senior, that you can view the patient's note while you are at home, and you have just a limited access. So this will help you for to discuss an important cases with your seniors, with the consultant, the handover, or during the patient's round. It deserves to ask about this access. We finish the handover, you finish the morning, sorry, the morning round. So it's really helpful to go to the each nurse who's handling the patient and give him update about the patients, what's happened. So after that, you guys will go to the handover room again, you will gather, and we discuss what happened during the morning rounds, what's your plan for the rest of the day. In this case, really, one of the nurses, the senior nurse will join you, you know, what are the cases, what the situation about the board round. Lunchtime refreshment is one important thing you need to make sure that you have it. Make yourself healthy. Some of the hospitals allow you to have your lunch during the second handover. So check about that. So don't be shy to have your lunch during the handover. And some of the other hospitals allow you to go to the cafeteria after the handover. So check which situation you are using the hospital and you can follow. This is the second important thing for this to show, which is the jobs. And this is the end result of the morning rounds. What you need to do for the patient, for example, cannulation, doing the child letter, make a referral. And if you are quite few people, you can divide yourself about these jobs. And if it's alone, I think you need to complete it and prioritize yourself and prioritize what the things you need to do. For example, if you want to do a cannulation for a septic patient, so you need to do it quickly and within 1 hour to give an antibiotic, which is really very important things. The nurses also will call you to do discharge letter, so you need to prioritize things for that as well. Don't forget you are the first on call. So you finish the morning round, expect that you receive a call from the nurses or from everywhere in the world if there is change in the patient conditions or there is concern about one patient. They will give you a plea, so make sure you get the right plea for you. You can see in the picture on the left side, the black machine. This is the plea. You have a specific number for each floor or for each ward. So if they need you, they will ring you in this plate and you see the number on this screen. You just see the number and go to the nearest phone, pick up the phone and call them and address their concern. Every hospital will try to make sure that you are fully aware how to use the plate and how you can answer it. So don't worry about that. Your time about to finish, which 5 a.m. or 4 p.m. or 5 p.m. Try not to involve in non-urgent job in the last hour so you can really make a proper handover. You can discuss with the seniors before endorsing to the next shift. Most of the morning shifts we go home. I'll leave you guys that one SHO registrar, the consultant, to continue care of the patients at a long day. And what is the meaning of the long day? That you continue from 4 p.m. or 5 p.m. up to the 9 p.m. before handover to the night shift. So this is a long day. The working environment is different according to the hospital you are working in. For example, if you are working at the tertiary center, in this case, you usually just allocated for one department, for example, neurology, NICU, or gastroenterology, because they are a big center. In the case of district hospital, usually small hospital, so you might make a rotation between different departments. You might work at the pediatric ward, which is caring patient up to 18 years old for 1 week. Then you go to the unit the next week, and you cover the pediatric assessment the other week. The pediatric assessment is like a small emergency department where the emergency doctor can refer some pediatric patient to you if they are worried about this patient, they need a pediatric review. You also expect a call from the community or from the primary health clinics. I mean, the GP practice, the community nurse, or the health visitors, if they concern about one patient, they are following the community to be assessed in pediatric. Enjoy the teamwork, enjoy every minute you are spending here in the NHS. Smile, keep a good relationship. Don't take things too hard. It's really very important. It's nothing personal. It's a new culture, new community, new hospital. All this is really fully understood. talk to someone you trust and talk to someone you know him, and everyone has their own problems. So it's not, I mean, uh, these guys are working in this hospital since they graduated from medical school and they know the system very well. So it's really very understandable that you are new to the area. You need the time to acclimatize and know how the condition looks like. So don't worry, I don't take things to your heart. Nursing staff, this is really a very important area we need to talk about. There's no superiority of one staff over other. So really all the teams are working together for the sake of the patients. I think it's quite important to keep these guys standing beside you. So one of the important things you can do it to keep these guys beside you is showing them their importance. And this is kind of simply done by some questions while you're making a patient round. Do you think that the baby is happy? The baby is fine to go home? Are you happy with the general condition about the baby? After all that, don't forget, guys, about your progression. You're here also to progress. So make sure that you have a supervisor and discuss with him the professional development plans that will help you in applying. And if you are trying to apply for a training or do your GMC appraisal by the end of the year, there is something called the study leave. So make sure, guys, you discuss with the HR how many study leave you have, how many days you have, and how you can utilize it, and when you can apply for that. It's quite important, guys, to improve your computer skills and tablet skills. And this is really very important for the SHO because we are the one who making documentation the most of the times. And if it's computerized, they already stand waiting for you to complete the documentation before go to other patients. So please try to improve your computerized skills. If you're still overseas, I can give these really two things for you. Improve your computer and tablet skills. Take your time. There's a lot of programs on the YouTube that can help you to make that. And bring your listening practice. When you come in here to UK, this is really a very large area, very different accent. So if you know in the area you are going to, so try to listen to the YouTube to the accent of that area and make yourself really acclimatized to this one. Thank you very much and enjoy the rest of the day.
Thank you, Mohammed. We will listen to the Registrar Day, an outline of Registrar Day in NHS by Eiman and Abubakr. And we will come back to take all the comments, all the opinions and all discussions at the end of the presentation. So for the next hour or so, let me welcome Dr. Eiman Hamid, a Paediatric Registrar trainee at ST4 level in West Yorkshire, and Dr. Abubakr Elawad, an ST5 Paediatric trainee in Nurse Wales and Merseyside. Eiman and Abubakr, we are all looking forward to hear and learn from you. Thank you.
Hi, everyone. Hi, Buran. Thank you for introducing me. Can you see my screen now?
Yeah.
All right. So the main reason why I prepared this talk, because when I joined the NHS, I joined in the registrar training post. So by the time when I was just about to join, I panicked, to be honest. I panicked about it. I panicked about the move to the UK. And although I knew that I have the enough experience and knowledge, still I panicked because I was going to join a senior post. So I've started to contact all the people who I know over here in the UK and ask them, I need the answer for one question. How does the day of the registrar in the NHS looks like? Just describe it to me and that's it. I don't want to know anything about the knowledge or the procedure or anything complicated. Just tell me how does the regular day looks like. And because I faced it and I know how scary it could sound, that's why I prepared this talk. So the main objectives for my talk today is to do an overview of the typical shifts of a pediatric registrar and tell you about the common procedures that you are expected to do as a registrar. We will go through handover and when to escalate, when to call for help, and this will be presented by my colleague Abubakr. And then I'll talk to you a bit about how to handle a safeguarding case, because I know many of the people abroad, safeguarding is a new area for them, and we don't face it a lot when we practice pediatrics overseas. And then we will talk a bit about how to handle your relationship with team members, and some of the extracurricular activities that are expected from a pediatric reg. And then we will finish our session with the questions and answers session. So let's start. So as you can see now, what I'm expected to do in each shift. So as a pediatric registrar, your rota will have 3 shift types. It's either a day shift, a twilight shift, or a night shift, and with a cross coverage. And the timing, there is a minor differences from deanery to deanery and from hospital to hospital. But let's start with the first shifts, which is the day shift. Usually the day shift is from 8:30 to 4:30 or from 9 to 5. As I said, minor differences from hospital to hospital. The shift usually starts with the consultant-led handover. So in the morning, you head to the handover room. The morning consultant, the registrar, the SHOs, plus the night team will be there. The night team will hand you the list for all the patients that are in the ward, the new patients and the patients who are already staying as an inpatient. And as Abdoun said, they will go through the safety huddle first to check the bed status, if there is any incidents that happened overnight, anything at all, and then they will go through the each patient. Pay an attention as a registrar for each patient they mention about, because usually what happens after the handover, when you go to the ward, you split the patients with your consultants. So you will do half of the round, and then the consultant will see some of the patients. Usually the consultant see the patient who is in the HDU, or some of the sick patients, or some of the patients that he's interested to see, and then you will see the others. Usually, as a registrar who is doing a day shift, your main object for that day is to relieve the pressure from the long day registrar, because usually there is a long day registrar who is covering till 9 p.m. So your job there is to do the ward round. And if you are in a DJH, sometimes you should cover the pediatric assessment unit as well. In our hospital, usually, if you are on standard day shift, you carry on the plebe. As I said, to relieve some of the pressure from the long day registrar. So you will receive the referrals from the A&E, from the community midwives, from the GP. You will utilize each referral, and then you will decide if you want to bring this patient up to the pediatric assessment unit and see them or not. So you will do some of the triaging and sorting out of stuff. So as I said, you will split the patients with your consultant. You will do the round on the patients. You may have an SHO with you, or you may not. It depends on the staffing and the junior staffing on that day. And then after that, you will meet up with your consultant to do the handover. So the consultant will go through his patients, I will go through my patients, and then you will discuss all the patients. If you are the long day registrar, you pay attention for my handover and his handover, because we need to know everyone else by the end of the day, all right? And then after that, after the handover, the SHO usually, as Mohammed Abdoun said, he will carry on with the jobs. And then you as a registrar, you can go to the pediatric assessment unit and start sorting out all the patients who were referred from the A&E and the community and everyone else. Your job as well is to check with the SHOs and see if they are struggling with something. If there is a referral or a difficult referral that they can't do it, or a consultation that they can't do it, you can do it yourself. In the NHS, there is no senior and junior. So usually if the list of the SHO is huge, you can split the jobs list with them. So you can do some of the cannulation, you can do the LPs. Usually you are expected as a registrar to supervise them in the LP. And then the quality of your day will depend on the quality of the SHO, to be honest. So as Mohammed Abdoun said, the SHO rota, it has everyone from a foundation year who know nothing about the pediatrics, to a GP trainee who still can know nothing about pediatrics, to an SHOs or a trainee who can be exposed to pediatric previously. So for example, if I had my day with someone like Mohammed Abdoun, who is already exposed to the pediatric and know exactly, this will be lovely. If my day is with an SHO who is a foundation year and doesn't know pediatrics, then I would be expected to supervise him, to help him with each procedure. Maybe at that day, as a registrar, you will do many of the procedures and many of the cannulation and many of the things. So just be mindful about that. that your day depends on the SHO that you have and the supervision that you need to give them as well. All right, this is your standard day shift in the PEDS ward. In the neonatal ward, it's still the same. You will do the handover, and then sometimes most of the NICU, you see the NICU patient with your consultant first, and then you crack on and do the rounds on the nursery, the transitional care units. And then the SHO, if he is on the postnatal wards, you as a reg, he will contact you as a reg for any patient that he needs a review. And if you have a transitional care unit in your neonatal unit, then you are expected to do the round over there and review each patient who is on IV antibiotic or on NAS scoring. And the babies on NAS scoring are the babies who are born 4 months on illicit drugs or medication, and they need to be reviewed daily by a pediatric reg. All right, this is the day shift. Now let's move to the second shift type, which is a twilight shift. Usually the twilight registrar is a helper, which means that you come in an overlapping shift between the day shifts and the night shift. So you try to help in the peak hours. The twilight shift in our hospital, we start at 2 p.m. and the shift ends by midnight. So it's from 2 to 12. There is a minor differences from hospital to hospital. Some hospital will have it from 4 p.m. to midnight. Some hospital will have it from 4 p.m. to 2 a.m. So as I said, it's just a shift in the middle of the day, and the main point is just to relieve the pressure from morning people and night people. Usually the twilight registrar, when you are doing a twilight shift, you cover the pediatric assessment unit. You are not involved in the ward so much because there's a long day registrar in the ward. So most of your work will be carrying the bleeps, receiving the referrals from the A&E. You can go down to the A&E and assess some of the very sick patients yourself, and triaging the patient. And if you don't know what do they mean by the pediatric assessment unit, usually it's part of the pediatric ward, and we accept all the patients in the pediatric assessment unit, and then we sort them out, and we see if they need an immediate discharge, or they need an admission, or they need a couple of hours of observation. For example, if there is a children with a viral induced wheeze that they are on 1 hourly or 2 hourly inhaler, and you think, well, I think he can go home, but he needs a few hours, so you'll keep him in the pediatric assessment unit. Or if there is a patient with a viral gastroenteritis and he needs a fluid challenge, so you keep him for a couple of hours in the pediatric assessment unit till he can pick up and then go home safely. So this is about the twilight shift. What about the night shift? So the night shift, most likely after the night shift, you will look like the picture that I put here, the photo. And the reason for that, it's quite scary, to be honest. The night shift is the scariest shift for all the registrars, especially when you are just in the start of your middle grade rota. So if you are an ST4 or ST5 equivalent, all right? What happens, you start at 9 p.m. The long day registrar and the long SHO will meet you, and then they will go through all the events that happen in the morning and all the patients, and then you start with crack on with the jobs. The issue with the night shift, that in some of the DGHs, there is only one registrar that covers the night shift. And this is, so when you are one registrar, you cover both the pediatric wards and the NICU. And this is what we call a cross coverage in the DGHs. In some of the hospitals, like the tertiary hospitals, or if the hospital has a large influx of patients, then you will have two separate registrars. So one of them will cover a pediatric ward, and the other one will cover the NICU, which is quite nice because at least you will feel that there is extra help with you, and someone will sort out the NICU for you. All right. The issues with the night shift, why most of the people get scared from the night shift is, as we said, short staffing. It's only you and your SHO. Second thing, that the consultant usually is off-site, so he is at home, but he is only, there is some rule in the NHS that any consultant on call, even if he is at home, he should be easily accessible and approachable. He's only one phone call away. And to be honest, our consultants, they're really supportive. So if you call them, they will be there within 10 minutes. I've never had to call the consultant and have wait for them for a long time. It's only 10 minutes till you find them in the ward. All right. In the night shift, it's all about you and your decisions and your supervision for your junior colleague, and how do you divide the work. As you said, you will be carrying the ward bleep, you will be carrying the PAU bleep, so you will receive almost calls from everywhere, and your SHO bleep as well when he calls you for help or support. My advice for you for night shift, don't be scared. You are supported. You are well supported, to be honest. And from my experience, if you are coming from Sudan or from Gulf area or from the Middle East, the practice here is totally different. Here you are well supported and you are expected to call, not like the other countries that we practice pediatrics before, when it's a shame for the registrar to call for something. And actually, when I observed the trainee here, the ST7 and the ST8 trainees, I found that they call even for stuff that I found that very tiny. But with time, I understood that this is how the NHS work out. You need to be a safe doctor. They don't look for superheroes who manage everything on their own. I think if you do this, then you will be considered as a non-safe doctor or someone who can jeopardize the patient safety. So don't think that you are expected to do everything on your own. And usually, if you are in doubt, should I call or should I wait till the morning or call now? Call. This is my best advice. If you are in doubt, always call. As I said, I've never encountered a consultant so far who shouted at me or who was unhappy. If you are getting paid to cover this night shift, he is getting paid to cover the night shift, so they will be welcoming. And it's just a tiny consultation, 10 seconds, 30 seconds. He will give you his opinion and then that's it. All right, this is for the night shift. If there's anything in the chat, please let me know, Boran, because I don't have a view for the chat at the moment. So this is the each shift type, and what are you expected to do in each shift type? Now, procedures. As a registrar in the pediatric wards, you are expected to master 2 procedures, the cannulation and the LP. And you see this yellow thing? I know it's a nightmare, and it could be the devil for you if you're coming from the Gulf area. I came from Qatar, and to be honest, like, cannulation was really the most horrible thing for me when I came, but it is what it is. It's part of our job prescription here. So if you are planning to do the move and come to the UK, please master your cannulation skills. As I said, when the SHO can't cannulate the patient, they will come to you as their registrar to cannulate the most difficult patients. When there is a recess in the A&E, usually they call the pediatric reg to come and cannulate the patient. And if you have even a simple standard day, but your SHO is not familiar with the pediatric, if he's a foundation year doctor or a GP trainee, then you are expected to do lots of cannulation on that day. So please master your cannulation skills. One of the things that I want to tell you about the upper cannula here, this is the Gelco cannula, and this is the cannula they use in the UK. Because if you're coming from Sudan or from Gulf area, you will be familiar with the Newfoundland cannula, the other one with the wings. But here they don't use the cannula with the wings, they use the other one. And to be honest, when I joined here, I didn't like it much because I was so used to the wings and manipulation the wings. But eventually the Gelco is really nice when you get used to it, just for you to know about this. In the neonate, the most common procedures as a pediatric registrar that you are expected to do is the cannulation, of course, and then the UVC, the UAC, and the long lines, the PEC lines. And it could look quite scary because I know in the, especially in the Gulf area, that they have a special PEC line team, and sometimes we used to send the patient to the interventional radiology to put the PEC lines. But here in the UK and the NHS, as a registrar, you are the one who are expected to put on the long line, the UVC and the UAC. So if you are planning to come and you didn't come yet, please make sure that you master this procedure, or at least you know them. Intubation, of course, for the term babies, you are expected to do as a reg. For extreme preterm, maybe after you do your neonatal rotation, then you are expected to master the extreme preterm intubation. But to be honest, no one will blame you if you did it and then you failed. Eventually, it is a difficult procedure. All right. I've just put this because when I was in the Gulf area, we didn't use to take capillary blood gas for our babies. We used to do a venous blood gas, and even I think in Sudan we do a venous blood gas for the neonates. But here they use a capillary blood gas. So they do the heel break here, and they use the lancet, and then they use the tube. They don't have the pen with the negative pressure like the one that we use in the neonatal units in the Gulf area. So just be mindful about that. There is a tiny differences even in the tiny instrument here, but it's part of your shadowing period, and then they will let you know about it as soon as you land in the NHS. Now let's speak about the handover and escalation. I will stop my share because this part will be addressed by my colleague Abubakr.
Hi, everyone. Thank you very much, Eiman. Thank you, Ron. My name is Abubakr Al-Mahdi, one of the ST5 Paediatric Registrar here in North Wales, UK. Hope the sound is clear. Before I start, I'm just going to share my screen. The slide is showing. I'm not yet sharing, right?
Can you see the share screen button down on the?
Yes.
Yeah, it's a green.
Yeah, the green one. I don't know why it's not sharing now. It's asking me a lot of questions here. Sorry, guys. I just don't know why.
Is he a co-host, Boran?
Yes.
It just don't want to share the screen. I don't know why. It just
Okay, if you can start the presentation and if you can send it to me, can I email you my email in the chat box? Is it okay?
share it by email or share it.
If you want to send it to me in email or in WhatsApp, and I will share it later for you.
Mm. 1 second. I send it, Ron.
Oh, thank you. Now you can start, and whenever I'm ready, and I will share it.
Okay. Right. So I'm just going to start while Eiman is trying to sort out the sharing slide. So yeah, so I'm Abubakr Elawad, one of the Paediatric Registrar, and today the presentation is about the Registrar Day. So as Eiman has said earlier in this presentation about how is the day going on. So I basically made this presentation mainly for those who's coming new to UK and to the system, or those kind of a new starter. For those who already here in UK, they might see that as a basic, but it's again important to share our experience and information, and then we can learn from each other. So basically today I'm going to talk about two things: about when to escalate, when to ask for help, and again about the clinical handover. So as you are as a registrar, you are expecting to participate more in management of patient independently. But again, you need to know your limitation. So then you will be facing a lot of clinical problem, many clinical challenges. So you need to know when and how to get help so you can sort out your problem. And the second thing that is about the handover. So this is two points that usually when you are a registrar, you will be doing it in a daily basis. So we'll start first with how and when to escalate and who can help you. Eiman, Paran, is any luck with the presentation?
It's already shared, Abubakr.
As already shared. Yeah.
Abubakr, just let me know when you want me to click.
Okay, so you will be controlling, right?
The next slide, yeah.
Right. You just hang on me here. Just hold on a second, sorry. It's always technical issues.
Can you see the slides?
No, I can't see it here. I don't know where it's gone. Right. It's all went viral now. Okay, yeah. Right, so we can go to the next slide, please. Right, so as Eiman said earlier, if you are the kind of a person that anxious or afraid to call his senior or his consultant during the night on call, so please don't be that person. Next slide, please. Yeah, so as Eiman said, there is no shame to call for help, to call your consultant. Usually, I know that the practice from overseas or from where we came is usually don't call the consultant unless it is life or death situation. So this is usually how the concept that when we're coming from outside into UK, and then when you came here, then you see the show is different. Here the consultant is part of the team and he is on call because he is there to give you help and support. And as Eiman said earlier, usually the consultant will not be like angry or be unhappy if you call. If they are not happy for any reason, then it's not your fault and they cannot say why you call me. But before you call, you need to know why you are calling. This is only the issue. So sometimes people get confused. When should I call? Shall I call? No. Is it something simple? What he will think about me if I call about this? But as Eiman said, if you're confused, if you want help, just call for help. But when you call, you need to know why I'm calling. But next slide. So yeah, so if you need help, then ask for help. That is in a simple way, because in other way, if you're not calling for help and things go wrong, then you will be the one that playing for this kind of a mistake of malmanagement. Even if you know sometimes the old treatment, then still you need to know when to inform your consultant. So sometimes you know how to treat this child. He's a sick child. I'm confident to treat him. I've seen before, but there is some situation. Then even if you know how to deal with this patient competently, you need to let your on-call consultant aware about the management. So so that can reflect on your that your limitation, that you know your limitation. Here, people, they will look for the doctor who are safe and he knows when to call, rather than one who is knowing everything and he can manage by his own. So always remember, you are a registrar. Registrar here doesn't mean that you are the as Eiman said, the superhero that he can deal with everything. Back home, when we're in Sudan, if you are the registrar, you're supposed to be the one that's running all the show, having all the competency and doing everything overnight, and don't bother your consultant. Here, no, you are a registrar, but between two brackets, you are still trainee, you're still learning. So there is no shame to call. There is no shame to say that, okay, I can do up to this, I can do more, but I cannot do that without any backup support from my consultant. So next slide. Right, so who can help? Then you have, either you are in the daytime, and usually during the daytime there is no issue, because you have a lot of your peers, your colleague within the floor, within the ward, the consultant is available. So there is a lot of team there that you can seek help. So it's usually there is no problem most of the time during the day, because you can ask. There is handover, there is people meeting all the time, they're all working as a team. If you don't know thing, just ask. Don't struggle trying to figure things by yourself. So always, if you don't know things, don't feel like, oh, if I said I don't know, that is a big shame. No, just ask, even if it is a symbol. So don't waste your time, especially when you are starting, to ask about help. Help can come from everyone in the world, from the nurses, it can come from your junior colleague. Even if you're the registrar, you can ask your consultant. You can find out even that your consultant, he doesn't know about this, but he can suggest for you what, who else you can ask or get help. Then it comes during the night on call, when you are the most senior medics on the ward. So then you are the one responsible on behalf of the consultant. Then sometimes you don't know everything, and especially if you are coming then in a different system for you. So again, don't feel ashamed that you say, okay, I'm new here, I don't know all of the system, can you help me? It's always about the way that you ask, rather than that you don't know. So if you ask in a nice way, you will find people very supportive, happy to help. If they know, if they don't know, they might suggest about what else you can do. So during the night shift, just next slide, I'll just move in run. Yeah, so your colleague on the floor. So sometimes if you're working in a tertiary hospital, you will be a part of a team of registrar that covering on-call, including the subspecialties or the admission. It depends on which where you're located. So you have a registrar sometimes with you in the floor. You can ask them for non-official advice, people that will not take responsibilities for your management at the end. So if you ask your registrar, always put in your mind, this is an advice, not kind of an official sometimes, because you not can say, all right, I've asked my colleague and he suggests blah, 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 blah. So always, when you are in doubt, there is a consultant, which is your senior. So because all the registrar, they will consider as they are registrar, maybe ST4, ST5, but at the end, all our registrar are trainee. But if it's something simple that you want to run it by someone and ask him, then you can ask him, all right, I've done these things. Do you think I should do it different? He might give you, oh, I think it's all right, it's fine. Or last time it's happened with me, and I called the consultant and it's fine. You can call him and just ask him for an advice, so they can support you with this one. Again, if you don't have a registrar with you, or the registrar is busy, don't forget the other people that can help you, and they can be very helpful, and the nurses. So, and the nurses are different here, and they are different level. When you came to UK and you work in UK, from level 1 with different grades. So there is a junior, there is a senior. I always find it useful when you can, especially during your night, introduce yourself, know who is the shift leader on the ward, because the shift leader can help you a lot, especially with the logistic problem during the night. If you don't know if they're struggling with things, struggling with bed, struggling with referral from ED, they can try to sort it. There is some sort, even when you are working in a district hospital, and there is a lot of stuff that we don't know, especially when you're coming like for people coming from mental support, mental health, thing that you don't know about it. They coming sometimes under different section. You don't know about what this is section. They call you from ED asking you, oh, this came with the police and their section, blah, blah, blah. What can you just receive this patient? And then you say, okay, fine, yeah, I'm gonna get this. And then you'll be in a big trouble because, oh, they came back, this patient came to the ward, and then you find out, all right, she should not come to the ward. She should have like another carer with them in the ward. You don't know that from before, and it's not usually something that someone teach you. So when you are not sure, usually it's always, don't say that, okay, right, fine, okay. If you don't know, you can say, okay, hold with me a second, I will get back to you. I just want to confirm with the ward, and then come to your team in the ward, the shift leader. I have this problem. Do you have an idea? What can we do here? Is it the normal pathway that we are accepting? I'm not sure about this. So you always they're helpful if you are approachable, and if you approach them from the start before the problem is happening. So always, if you are in the night and you are new, come and introduce yourself. The registrar on call today, I'm new here, I'm new to the system, so I will appreciate any help from you, and I will come to ask for anything. Is that okay? So always anticipate that, get them in your side. That will be very helpful and save you a lot of time. Next one. Okay, so you exhaust all your help in the ward, and then you are stuck. You don't have any other from your sleeping consultant at home. So how you gonna talk to him now? So you're sitting and you have this problem, and I need to call him. Next. Okay, so there is situation that you have to call your consultant and let him know. So that is the way that if you don't call him in this situation, in this scenario, you will be blamed next morning, even if you treat the patient exactly like what he's gonna do. So next. So if you got a sick patient that need an escalation, patient on the ward that you need to go to the HDU, then you can do the step. If the patient is critical, I mean, you need to have this step right now, it's fine. But is this something that you're planning to, then call your consultant, get him involved, and then he might say, okay, yeah, that's fine, but you need to get him involved in that before you proceed, before you're shifting patient like to HDU. You don't want your consultant to come in the morning and you say, oh, that patient has been moved to the HDU without his awareness. So you have to do that one. Next. And then if you got on a sick patient that's likely to deteriorate, so if you're anticipating any patient that he came unwell initially, you are stabilizing him, but you think this patient might not go well through the night, then it is wiser to give the consultant a heads, like from the start, I got this one, he is sick, I'm stabilizing him, he's doing like this and like that. But in case that he got deteriorated, just to let you know about that. So this is, again, you don't want to call your consultant when you are starting resus or you're starting bagging for a baby. If you are anticipating that earlier, let him with you so he will know when you call him or you are busy and you got to the patient, then you can ask the nurse, okay, can you call the consultant? Even you don't need to call him yourself. You can ask the nurse, he knows about the patient, he will know the background, who is treated, immediately come without all the kind of that history. Next. Then Eiman will come and talk about the safeguarding concern, but again, this is one of the points that you need to call your consultant before you taking any action. This is when you have to. There is no excuse. You don't call your consultant. So if you have any concern about safeguarding, before you proceed further about the track for the safeguarding, your consultant need to know about that, because it's a medical legal issues that she need to know and support you. again, if you're involving other specialty, especially if you are in a district hospital, when you are in tertiary, all the other specialties is around you. So that is easy to get the second opinion, even from the registrar or from the consultant, because you can see him in the ward anyway. But in general, if you need to involve other specialties, especially if you are in district hospital, for example, if the patient came and you want to discuss the hematology team on other hospital because you are suspecting something on the results or anything, let your consultant know before you ask them, because it will be not a good picture if the consultant being contacted by the other specialty and he doesn't know anything about the patient. Because sometimes you call the consultant, I got the blah 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 overnight, and then in the morning they will hand it over to that team. The consultant, maybe he needs some few information, he will call the consultant. He will not call you as a registrar. He will call the consultant. Oh, they are calling me about your patient, blah blah, and I think he need this and this, and then the consultant, no, I don't know about this patient. So he will come and he will be furious and informing him. And then again, sometimes when you are on call, you can be in a busy night when you have a multiple patient that they are sick, and they all need a medical attention at the same point. So at midbound in the HDU, they're calling in from unwell baby on the emergency department. You got an unit who is septic and need LP to start antibiotic, and that is busy. They're having a patient. That time you need to get help. You need to get backup. You need to inform your consultant, like, I am in this situation. I got many patients sick with me. I need you to come. Don't be shy to say that, because otherwise you think it in the other way. If those babies, anything happened that you couldn't, because you are not, because you are lazy, but you have been distracted by someone else, but you know that there is someone sick and you didn't call your consultant, then this is your responsibilities, because he will tell you that I'm here, why you didn't call me. So again and again and again, consultant, they are usually approachable and they will come. So basically, don't overthinking. If you feel that I need to call someone for help, ask from wherever they are, and don't forget there is a consultant who is there to help you. Don't feel, if you're feeling silly or you're feeling this is a stupid question, just ask that stupid question and just get it out of your head. Right. So that will get take us to the how I can call the consultant. What should I say? In which way that I would say. So here usually they have an structural way to talk about patient. And next. So that I was calling a SPAR. So the way that you communicate your patient with other professional is through a systemic way that the listener will expect you to tell him this bit. So what is SPAR? Next. So SPAR, I mean, it's been used by the before by the Navy, by military in US, and they found it efficient, so it's adopted by the health system. And SPAR is so the S is for the situation, which is, i.e., a concise statement of the problem. Some people will add I before the situation, which is identify. That means who you are. So sometimes take it, this is biologic. If I call, I need to tell who I am. But again, from us, when we're coming from overseas, it might be tricky because you're assuming that you are on call consultant. Your consultant know who is his registrar on the ward. It's not always the case. So sometimes you call the consultant on call who is only on call from 5 p.m. to the morning. So he doesn't know who the registrar in the morning. He may not be interested to ask who is the registrar because they're all the same. Not differences. Brand is doing the registrar, or maybe they ask in the background, but they don't usually ask. So always when you talk to someone over the phone, don't assume that he knows you. So I am Abubakr, I'm the on-call consultant, I'm on-call registrar tonight. I'm calling you from the ward for this reason. So usually you can make it in a state, especially you're calling the consultant, he don't want to hear all the blah, 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 I'm calling for this. So this is the situation. You need a concise statement of the problem, why you are calling now at this moment. I'm calling for advice. I'm calling you to pick up your head for something. I want you to get a support from you for something. Next. And then the B is for the background and the history. So it is the important and the brief relevant information to the situation. So for example, what the reason for admission, what the diagnosis of this patient, what is the current management of this patient. Again, don't assume that the consultant know about the patient. Even the consultant, if he knows about the patient, he will not say, maybe he will say, okay, I know him. Or even if he know him, he will wait for you to tell, because he sometimes maybe he missing something about the history earlier. And then you will say, okay, you said that you know all the things, so you know about that potassium, that's why I didn't tell you. So they usually stay silent, waiting for you to say all the history and relevant information, because he will take it from you tomorrow. He will say, you tell me this and this, you didn't mention about the potassium, unless he know it and remember. And I said, okay, fine, yeah, this one was the potassium, okay, fine. But don't assume that the consultant knows about everything about the patient. So take that as a new one that I want just to inform him. And then we'll go for the A, which is the assessment and your impression. So you got the history, what you have assessed the patient, you went and you see the patient, and then what's your impression? What you think about this patient? And then we'll go to the R, which is the recommendation. So what do you want? And you can hear that question if you were being vague. So the consultant will ask you, so what is the question? If you're being fuming and saying different things. So if you don't have that question in your mind, please make it before you call. So why I'm calling you? Either, right, I'm calling you because I don't know, I never managed case like this before, but I've done my bits. So what do you want me to do more, or are you happy with this plan? As I said, there is some situation that you have to tell him because he need to know. So I've done this and this and this and this, but I'm just calling to let you know that I've done. Do you want me to do something different, or you're happy with this one? So it's not always about I want to ask. So sometimes I want to just double check with you. So this is then the recommendation. Right, next. So I will just take this a kind of an example that you and then see how we can do so. I can give you 2 minutes. I don't know if you're okay with the time now. Are we still having some time? Maybe we'll finish in
I think we're
7
fine,
minutes.
yeah.
Okay.
We're fine.
So this is an example. If you think you can have a read for the examples and then think about how I can hand over this patient. So it is in 2 slides. So this is slide and then the next slide. So the first slide, I will just read it. Maybe it will be easier. So you are the on-call registrar, 93 o'clock in the morning, and assume that it is in a busy night. So there's a 29 days baby girl X, and this is like a true story. So 29 days baby girl X admitted 5 days ago with a history of apnea. There's been admitted in the working diagnosis about tough tracheoesophageal fistula, not cardiac tough. She's currently NG feeding as a part of the treatment, and she's awaiting for radiological test for to confirm the initial or the working diagnosis of tough. However, X continues to have apneas, and the nurse asks you that night to come and review X as she's having more frequent apneas compared to her last night. Next. Or you'd wait for them to read it. So she's currently self-ventilating in air. Sometimes, maybe if you're coming new, you may be struggling with the abbreviation. So again, don't feel ashamed to ask what that meaning, because they're using different abbreviation for different. So self-ventilating in air, or she's in air, that is common abbreviation, but with frequent dips in her saturation. So she tolerates her feeding And nurses reported that her desaturation and apnea is not linked to her feeding. So you went and you assessed the patient and you noted supra and sternal recession and inspiratory stridor. So when you applied a jaw thrust you observe improvement on her saturation and work of breathing. You have done a blood gas and showed compensated respiratory acidosis. So at that point, you suspected upper airway problem, and you are thinking of shifting the patient to the high dependency unit and support the baby with a positive pressure just to overcome any upper airway disease or upper airway obstruction from assessment. You also consider screening for sepsis and start IV antibiotic. Next. Okay. So remember that sleepy consultant, he's still sleeping 3 a.m. in the morning, and now you are calling the consultant to get his opinion on this management. As we said, if you're escalating patient, then this is a time when you have to call the consultant. So there is no shame here that I'm going to call him, but what you're going to say to him, you have this kind of a story. So have a 2 minutes just thinking what you're going to do, how you're going to convey this message to the consultant about this patient, and what do you want from the consultant here. 1 minute we give.
Abubakr, do you want a volunteer to try handover, or do you want to do it yourself?
We'll do it together. I mean, we can do it like in the break it down. I'm gonna do it. I just want the audience just to have the chance that to see between them how I'm gonna do like to hand over. If someone wants to volunteer, that would be brilliant. Okay, so we can move on and see if someone wants to volunteer. I can't see any hand raised, so that's fine. Okay, so how we're gonna give the handover. So again, we said we're gonna follow the SPAR. So first of all, the S. So you pick up the phone. Hello, I am blah, blah, blah. I am the on-call registrar. I'm calling you about patient X in the pediatric ward. So you have to identify who you are. And then you said from where you are calling, who you're calling about. And then the reason I'm calling, patient X has more frequent desaturation and apnea. So you pick him attention why I'm calling about that patient because of this problem. This is what now. Okay, next. Then from this history is the background. So then you will tell him about the background about the patient, the same thing that you already picked up from the history from the note. So then you tell him that patient X of the background, patient X was admitted 5 days ago with a history of apnea related to feed, and she's under investigation for possible diagnosis of tracheoesophageal fistula. She is currently on NG feeding and she's awaiting contrast X-ray. Patient X continued to have episode of apnea since admission despite initial plan. So I have been to review her as she has more frequent episode in the last few hours. The nurse does not think it is related to her feeding because they are putting the NG feeding, and you know that the plan for the NG feeding is to overcome if there is any tough here and then that causing the apneas initially. So they have made an initial plan, but obviously the initial plan not working fine. So and then back of the background, X was born tame and there is no early neonatal concern apart from this 5 days history that she came in with. Then you go for your assessment, and this is what the kind of the scenario that your consultant will be waiting to hear. So now the assessment. So on my examination, she was handling well. She's an air when I saw her, but she got frequent dips in her saturation. I noted also recession, and that recession was suprasternal recession with a strider. So what action you have done at that point for the patient, if you've done any action. So this desaturation improved with when I applied your thrust and I did a gas, and the gas showed respiratory acidosis. And then part of your assessment is your impression. So I suspected upper airway disease or obstruction. So now the consultant know what you are thinking. So then your recommendation, you can't just throw all the information to your consultant and then pause. Okay, what you want me to do? No, you have to tell him what's your impression, what you have done so far. So you have to do your bits, you have to do your research, you have to know the history. If you ask about anything, you need to know about the investigation, everything, and then come to your recommendation. So what you want from me. So you already have your plan now. Okay, I suspected upper airway. So what I thinking to do, or I'm thinking to do, is I want to shift her to HGDU to commence her on CPAP, for example, just to overcome her upper airway. This is your thinking. It might be false, it might be wrong, but there is no harm to say what you are thinking. And then I want, obviously, I want an ENT review at earliest point for this patient. So at least in the morning, he might wake up the consultant. He know that there is a patient that need ENT. So he might know the consultant, and we ring him first thing in the morning before he came to the ward round. Okay, oh, I got one patient. I didn't see him yet, but my registrar yesterday was concerned about this. We went have for this. Could you just come and see? I'm going to see her later and let you know. So the ENT know from the morning, you know, the consultant. So it's easier. And then why calling you? I want to see if you're happy with this plan, if you're suggesting something different, if you want me to do something different from this one. And then you will wait from the consultant. He might just say, okay, fine, I'm happy. And peep, peep, nothing like 2 words or 3 words. Or he might ask you further about, oh, do this one, do that one. And then he will be expecting you. So this is a sick patient that might deteriorate even if you are thinking him. So you call him initially because you are escalating him, but at the same time, this patient likely might deteriorate because you are just starting initial plan. You don't know what exactly going with this patient. So if you ring him the next time, oh, I'm ringing you up at patient X again, so he know the history. You don't need to go all about all this kind of SPAR again. I'm calling him because he is deteriorating. And then if there is any action you have done, then you go again with that one. But you already know that what the situation, what the background. If there is change in that new assessment and your recommendation, then you need to call back again. Right. So again, SPAR is not just using for calling consultant. You can use this SPAR for the handover, for calling other hospital, calling transport team, between the nurses, between you and the nurse. This is the way that you need always to stick to. Don't come with your own way of doing handover. Yeah, you can modify. You can modify within the story, but you have to include all this part in your handover. So it can be an inpatient, outpatient, urgent or non-urgent communication and between teams. So we have like kind of an example when you have using the handover to your consultant, the phone. But the thing that, again, you're going to do it in a regular pace is the handover between shift changes. So next. Right. So shift change handover. This is a common thing that you always be if you are on call. If you're coming in the morning, seeing others doing handover, or if you're coming or you are doing the night shift and then you are handover to the team. So again, as a registrar, so as an SHO, you might be partially involved with the handover. Some area they are giving the handover to the SHO to do the handover. But it's always the responsibility of the on-call registrar. Even if you're SHO doing the handover, it's your responsibility to make sure that this handover. So you are supervising the SHO. So if there is something missing, you have to back up him about this. So there is a morning handover, and there is that morning handover from the night team to the morning team. And then you have the evening handover, which is after 5 o'clock, because usually there is a long day person. And then there is a night team when there's the evening person hand over to the night team. Next. Those are like the main. Then there is something called the post-round take. So like after the ward round, all the sitting together, and again, everyone contribute to the patient that they saw during the round. But will not be a one-person show like doing the handover. Here, all the team will participate on your handover. So wherever I saw a patient, I will give the handover. But again, I will give the handover through the SPAR. Then next, then as my colleague mentioned again, there is some unit that they go through the huddles, the morning huddles, mainly with the intensive care in the unit or in the PICU. They usually like to do the huddles, and the huddles is a quick handover for all of the floor, that including the nurses. They always meet in the morning, so it's a good mapping for the day rather than giving the patient handover itself. But you need to hand over the things related to the patient and the work in the ward. So who is the staffing today, who is missing today, who's covering this and covering this. So planning of the day rather than giving. But again, there is a bit of the handover that you hand over, who is going for discharge, who is expecting, if there is any problem during the night. So it is not a patient transfer kind of information rather than planning of all the management of during the day. And the thing that we'll be more involved with, and you need to focus on, which is the night, which is the morning handover when you are covering your night shift, because you're in on. So this is the one that you're gonna run all the show by you as a registrar with the help of the test show. So yeah, so again, because that is where this you are one, and again put in your mind the people that you are giving the handover. So Brian, if you go back to the previous slide. So in the morning team, so if you give like the evening team handover, as I said, all of them, they are participating. If you went to the night on call, you are always like registrar to registrar handover, so one-to-one. So it's more easy. It's more like formal but friendly, because you can have an interruption. You can tell all your thought freely, like with your colleague. Oh, I've seen this one, and he can discuss with you. It's just one-to-one. So again, consider how many people in the handover can differ. But when you came to the morning handover here, you have to hand over many patients to different team who knows who the one is new, the consultant is new. So you need to know your audience, who is there, who want to listen. If you are handover for the night team to the same registrar, and this is the third night and you're third on call, so all of you know that what is going on about the patient, and you know everything from the last night, so it's easier, we can just go quickly. But you came in the handover, you know that this one has no idea about this patient, this one knows about this patient. So you have to know your audience, and I'm delivering, like, for example, 10 or 15 patients. I want to go through all of them as a handover and stick to my SPAR. So then it is a skills that you need to practice. Okay, next. So I call it the power of handover. So it's not handover yet. It is made for the sake of the patient. But you are here as a registrar or wherever, like working in the NHS. It is about what you want to gain from everything you do here. It is an hard work, so you have some reward from that. And because here, when you're working in UK, nothing comes easy. Everything that you want to get, you have to work for it. So you are doing a lot of work. You're doing the handover, but what that handover can help you yourself. Don't forget that handover is a summary of your hard 12-hour shifting overnight. So this is your report for that one. So this is the time when you can show and reflect your clinical thinking, your clinical judgment, because you're facing some problem overnight. You have to highlight that things, and that again give the impression for the team who you are, what you have done. Don't be shy or underestimate what you have done overnight. If you done something good, make sure that you highlight this issue in the morning round, because now you are facing all the team. All the team is listening to you, looking at you. So you have to do that report. You have to reflect that 12-hour working last night in a good way. Sometimes you came to the work, you have seen 20 patients, you have discharged 20 patients. You came in the morning and you said there is no admission. Thank you. You're gone. Then you have not done anything overnight. No one will know that there is only 20 patient came here and being discharged. So yeah, that is not gonna affect the management that day, is there is no discharge, but you have done a lot of things overnight. I won't reflect on that. I've seen 20 patient overnight. Yet we don't have admission, but that can reflect you have discharged it all. There is no problem next morning. That means you have done all of them. That's good. It's fine. You manage. You don't have any necessarily admission, but don't forget that to use the handover to your side. And then the communication skills, people are gonna look at you and they want to know. Again, we are coming from a different background, different culture. Initially, we might be struggling. Don't try to mimic other people. They are confident in doing that. Their language, they're using things. They're working here for a while. So don't be too stressed about that. Try to be brief, concise, and just do it in the right way, and just say what happened yesterday, what kind of no problem, and with time you will get that one quickly. So make sure that you can maintain your eye-to-eye contact, your voice, your tone, and keep your audience attention. So you have to be prepared for the handover. It's not easy to hand over 15 or 20 patients all of a sudden, especially the night. So give yourself time before the handover. And again, remember, because sometimes people just misunderstand that the handover is just, I'm going to give the handover, it is half. No, handover is important as your clinical care. So you have to hand over. You mean to make sure that patients are safe. So again, if you have, for example, non-urgent patient to be seen like 8:30 in the morning, and your handover is at 9 o'clock, and that patient just came, it's nothing, it's like maybe fever, settling, it looks fine, nurses are not concerned, and you still want to make your handover. So handover is important, so it's priority again. So again, you have to prioritize your handover within your clinical work, because it's very important. You're handing over all the care of the patient to them. So try to find some time before the handover. Next. And then the good thing that you don't have to memorize all the patient. So there's usually like there is usually a handover sheet when there is the important note there, and this is your job to fill this area with the thing that you want to remember, you think that is highlighted, it's important. So all information you can put here, but again, you have to be reasonable about the information. But so it is your time to tie it up. So most of the time, the USHO will help you to do all this updating the list. But again, it is your responsibility what you want to be on that list. So sit with your SHO. SHO can hand over, can update the list during the night, but make sure before the handover, you're sitting with him, you're going through the list, you're making sure all investigation has been chased, has been on the list, all the jobs has been updated, and be prepared because this is your show now. Next. Again, time. So it's always about time. So handover is usually have a limited time, has a design time that you need to know about it. So if it is usually maybe around 30 minutes, so I need to hand over through from this 30 minutes. If you go beyond the 30 minutes, that you are compromising the work. So it's not something good. And then again, that would reflect on your time management. So you have to practice to give this handover within the time. So not to be too slow, not to be too in hurry for that one. You have to be concise and brief, and that comes with practice again. Next, so practice and practice and practice. This is how you can get the skills of giving a handover. And I always see that every time, whenever you give a handover, you say, "Oh, I need to give that one. It should be better on this one. Oh, I must be slow." So get that one. We'll not get used to the handover before. So be sure, because you don't want to miss an important fact about this patient and you left. And then you come back next morning, oh, you didn't tell us about this potassium. And here people, they are memorizing everything. It sometimes looks like they're not listening to you, but they are getting it. Oh, you didn't say that, what in handover. And always, when you are new, get feedback from your colleague, do any handover, get your supervisor, get your consultant. Okay, I'm going to do the handover. I'm new to the system and the handover. Could you please listen to me just before you're giving the handover? You know, people here go ask them, I'm going to give the handover. Please, when I finish, give me a feedback about my handover. I'm still learning about it. They will be so open. They'll give you a nice point that you might not need. Sometimes people, you are talking and you're giving a lot of maybe sounds in between or pauses or everything, and then, oh, just be careful, you are saying this word a lot of time, or you're saying this one or saying this one. So it's good to have a feedback from other people. And I think I'm done from the presentation. Hopefully I'm not taking much from you, Eiman.
It's all right. I can't stress enough on the importance of the handover. So to be honest, as a registrar, it's the most important part of of your skills to master, because it's the only way how your consultant will judge you. So thank you so much, Abubakr, for this valuable presentation. The interaction between the registrar and consultant is very minimal. It's only about the handover, and that's why initially they can judge you. So please, for the newcomers, if you can just practice your structured handover, this will be really helpful. And the trick that I used to do when I first joined, I used to observe the handover of the senior trainees and the British trainees, and then they use a certain buzzword and a certain terminology. And if you like something, just memorize it or write it down and then practice it and use it in your own handover. This is really important if you're coming new. Before leaving the escalation part, because I've received many messages from people who just really joined recently, and they were asking me if you're in the DGH and the patient is sick and deteriorating, and I know that I can call the consultant and he will be there within 10 minutes, but still they were worried about the intubation and stuff. I need you to know that there is a great support from the anesthetic team in the DGHs. So if the patient is crashing down, the anesthetic team they are a part of the crash bleep. Even if the patient is not crashing, you still can call them and they will come. They will assess the airway with you. They will support you with the intubation, and they can help you with a very difficult cannulation sometimes because they can come over and do an ultrasound guided cannulation. So there's a great support from the anesthetic team in the DGH. So don't forget about that, and don't worry about that. And as Abubakr said, if you have many sick patients, or if you are doing a cross coverage like we do in our hospital, then it's totally acceptable to call. So if you are busy in the pediatric and something happened in the SCBU, you can call the SCBU consultant and he will happily come over to manage the SCBU. And the other way around, if you are busy in the SCBU and then something happened in the pediatric, you can call the pediatric consultant. And sometimes the nurse in charge herself, she can call the consultant and he will come happily and assist the patients. And then the last thing that Abubakr touched on, that if you don't know, like if the clinical case is new for you, don't be shy, as Abubakr said. Just say, this is my first encounter with such a case, but please always check the local trust guidelines. And there's something here that I really admire with the NHS. Even the consultant, if you ask them something about the management or something, they never answer directly from their mind. They just sit down, they check the local trust guidelines. They always check the trust guidelines or NICE guidelines or something in the computer, and then they will answer. So no one is ashamed to say, I need to double check, even if you know it by heart. Still, it's totally acceptable for you as a registrar to sit and check the guidelines and then call and then take a decision. All right. So there is many ways of support before escalation. And the scenario of Abubakr is very common when you see a 16 patient or 14 patient or 20 patients, and then you charge all of them. And then in the morning, some people will ask, well, how I will be 100% confident to manage a 16 patients and send them home. But usually when you are new, it's totally acceptable for you to put some of the patients that you have some doubts about them in the bottom of the list. And then just in the morning, you tell the patient, well, yesterday, you tell the consultant, yesterday I saw this and this, I discharged them home because they looked fine, but I did this and this, or I had a question on this. Do you think this one's right? Do you think I should refer him to your clinic? Something like that. So you can keep like a list of the patients apart and then ask in the handover as well. Now let's move to the how to handle a safeguarding case. So safeguarding is a very scary zone for us, people who are coming from abroad, because to be honest, we are not involved in the safeguarding by any chance. I was a pediatric trainee in Qatar, and to be honest, I've never encountered a safeguarding case myself. And the rules are different, the policies are different, and everything are different. But by the way, by the time that you are a pediatric registrar, most likely 100% you passed your RCPCH exam, so you are familiar with that thing. Usually, when do you encounter a safeguarding case as a registrar? It's either in the ward setting or in the clinic. If it's in the clinic, it's very simple, because usually it's a dedicated safeguarding clinic or a child protection clinic. And usually in clinics, you have your consultant over there. So usually you will know the case from the beginning. You will have the referral from the social worker from the beginning, and you just crack on with the case. The thing happens when the case comes in the ward or in the pediatric assessment unit. So usually, how do we tackle this? First of all, you will receive a referral. Usually 90% from the cases, the referral will come from the A&E or from the social team through your plea. And the scenario, 90% of the case would be, well, we had a non-mobile child. He came with a physical injury or a bruise or something, or head or boogie head swelling or anything, or he went for the GP, and the GP, while examining him, he found a bruise, and then he referred him to us, and this initiated the non-accidental injury cascade. Each hospital, each trust has their own safeguarding policy. It's always the same by the end of the day, but it's worth checking when you start your job, just to check your hospital safeguarding policy. But usually this is how the referral will come to you. So we have a case, it's a bruise, it's initiated the non-accidental injury pathway, and we have to refer her to the pediatrician. First thing to do is to inform your consultant, as Abubakr said. This is one of the red flags, that you have to inform your consultant. Even if you are 100% sure about the case, still you have to inform your consultant. The STA trainees that I saw, they still discuss the cases with the consultants, all right? So this is the first thing, you inform your consultant. We are expecting a safeguarding case coming from the A&E, or if the patient landed in your pediatric assessment ward, and then it's fine, and you saw him and he is doing well, then it's fine. You can start by history and examination and then inform your consultant. But eventually you have to inform your consultant about a safeguarding case. If a safeguarding case landed on by the middle of the night, 2 a.m., 3 a.m., 5 a.m., you have to inform your consultant in the middle of the night. And why is that? Because usually the night consultant gives a handover to the morning consultant, and one of the things that the morning consultant needs to know about it, that if there is a safeguarding case in the ward waiting for him or not, because the consultant needs to clear his schedule, because in a safeguarding case admitted over the night, we need a strategy meeting on the daytime. So the consultant needs to know ahead, since early in the morning, that, well, there is a safeguarding case. I need to check on it. I need to find the time in my agenda for the strategy meeting. All right. So this is the first thing. You will inform your consultant that you have a safeguarding case. The second thing that you need to do is to start with the history. And usually what we use is the child protection companion. So this is the link for the child protection companion. It's part from the RCPCH website. And then when you log in, you will find all the steps, all the points that you need to take in the history, all the points that you need to check in the examination and the recommendation, and it will have all the sections there. It will help you to formulate even your summary and your opinion, and even in writing the report, you can take parts from them and use it as a reference for your recommendation. So you will take the history, you take a proper history. Please don't forget about the social history. You need to clarify with the social history, who did you take it from, the name of the mom, the name of the dad, their date of birth. Most of the hospitals, when they deal with the safeguarding case, they will have a child protection document with them. So the document will be like a small file, and then you will have all the section of the history that need to be filled section by section: immunization, social history, the social worker who referred this patient, everything. And then you will have an examination part, and in the examination part there is a body map like the one here in the slide, and then you mark all of the injuries and all of the bruises, and you have to write what was the measurement of those bruises. So you measure them with the measuring tape, and then you put all the bruises and all the marks on the body map. And make sure that you arrange for a medical photography. If there is no medical photography overnight, you put the request for the morning to be for them to come and take the photos as well. All right. So after the history, after the examination, and you examine from head to toe, and you put all the injuries and all the bruises, as I said, it should be a very detailed note, and it should be a very detailed documentation. So in our hospital, if it's an inpatient, we write it in the electronic system. But if it's in the clinic, then we have the safeguarding document that we document on it. All right. And then you formulate your impression. So if you think it's accidental, it's non-accidental. If the mechanism of injury makes sense to you, it does not make sense to you, you need to formulate your own opinion. And then you call your consultant and tell them, well, I've seen the case, this is the history, this is the examination, this is my opinion, I've documented everything. And then you'll discuss it with your consultant. Most of the cases, especially if there's a head injury or something, you will call the consultant either way, because you will be thinking about a CT, because usually we CT the baby, especially the one who came with the big swelling of the in the head, or a big bruises or something like that. So anyway, you'll be calling the consultant to tell them that, well, I've got the patient, those are the injuries, and I will arrange for a CT, and then you will have a green light from your consultant, and then you will continue with your unaccidental pathway, and then you will request the bloods and skeletal survey and everything. All right. So this is the basics. So inform your consultant, take a thorough history, do the examination. Don't forget about the body mapping and the body mapping and the medical photography, and use the child protection companion, because it's really a useful guide for you for the history, for the examination, and it will relate all the injuries that the babies have. Like, for example, if the baby has if the CT showed that there is a linear fracture, or a linear skull fracture, for example, then he either had a significant blow to the head, or he fell out of 3 feet, for example. So it's really useful to know those tips and tricks. So please check the child protection companion for that. Now, how to manage your relationship with the team members at the NHS. For someone who is new, this is a really challenging thing. I do think that managing a relationship with team members requires a significant amount of emotional intelligence. And as a registrar, you need to manage your junior staff, consultants, supervisors, nurses, and allied health workers. So let's start with the junior staff. Usually what you are expected from the as a registrar is to guide the junior staff, is to offer them all the help that you can. And as I said, it differs if you got your amount of supervision will differ whether you got a very junior SHO from a senior SHO from a middle grade. So you need to evaluate who do you got in the rota for this day or for this week? What type of supervision? Are you going to micromanage them in everything? Are you giving them some amount of independence and let them evaluate, and then just reevaluate after them? So it's a balance issue. You are expected to teach them as well. So bedside teaching, supervision for the procedures. There are teaching days as well. Each hospital has its own teaching days. So you are expected to teach them. You are expected to guide them, and you are expected to be the best role model that they can see. And one of the things that I see that it's very useful, it's always praise them. So praise your SHOs. If they've done a good thing, then just mention it. Always thank them. Always double check if they had their breaks or not, because usually shifts are really busy. And just check after your junior staff. All right. And when I got my MSF, which is the feedback, I found it. I was really amazed when most of the juniors, they said, well, Eiman is really supportive, Eiman is approachable, but all of them mentioned one thing: Eiman always appraise us and acknowledge us when we do something right, which I didn't think that it would change their life, or that it has a significant effect on them. So if an SHO done a difficult cannula, and then it was mention it in the handover, and say, well, today X, we had difficult patient with difficult cannula, and X managed to get it from the first time. And it will make their day, and this will keep them going. All right. So this is your part as a registrar. With your consultant, you are expected to respect them, but you are expected to show your leadership skills as well. So they expect from you, apart from the clinical management of the patients and having a good handover and having a solid management, they expect you to be initiative in terms of problem solving. So usually if you got an issue in the ward, for example, a difficult parent or something logistic, they don't expect you to pick up a phone and then say, well, this happened and this is the issue, because this is an SHO level. So to some extent they expect you to find a bit of solution, or at least try something, and then if it fails, then call them. So so this is the expectation from you as a registrar, to be a decision maker at some point, and to be initiating and try to solve some of the problems. All right, and then don't forget to include them and let them know. Don't do anything without letting your consultant know. For a supervisor, keep them in the loop. Keep your education supervisor and clinical supervisor in the loop. For your clinical supervisor, usual clinical supervisor is very close to you, so he will know about everything. If you've done a great stuff in the ward, let them know. If you are struggling with something, let them know. They will offer all the help and support that you can. If you are in a trust job, then they will help you to get the training, get the courses. They will advise you regarding your examination. So I'll keep them in the loop and keep them in be in close communication with them. And you will be surprised on the doors that they can offer you, and they can open you on the solution that they can give you. Nurses and allied health. I know that there is a big propaganda about the NHS nurses, and many people say they are totally different than the nurses that we are used to back home. And this is right, but not in a bad way, to be honest, because as your job prescription is totally different here than back home, the nurses' job prescription is totally different here than back home. The nurses in NHS, they have a great deal of autonomy and independence, and as a doctor here, we have a great deal of autonomy and independence as well. The NHS is understaffed and it's really overwhelmed, so the nurses are really busy with lots of admin job, and that's what. Hello. All right. So they're really busy with the admin job, and that's why this is the thing that we need to understand, that back home or overseas, the nurses, they are only devoted for the clinical jobs and doing the cannulation and stuff and just listening to our orders. Here, no, they have other stuff to do as well. The second thing that you need to know, that the NHS is a nurse-led system. So the nurse that you face in the ward, she's been in the same ward for 6, 7, or 8 years. But you are the new one who will stay there for 6 months or 1 year and then move. So she's more valuable than you, to be honest. And when you are the new face in the system or the new face in the ward, they will make sure that they will mark their territory, and they will let you know that they have been here before you. They will know better. So don't take it personally. It's just the way how things goes. Initially, you may struggle because you will have the language barrier, you will have the cultural barrier, you will not know how to approach them. But just please, if you find any unprofessional behavior, don't respond back with the unprofessional behavior, because if you snap, everyone will forget about who provoked you or what was the reason, or everyone will just remember your unprofessional behavior. So if they advise you regarding something or comment about something, smile, take the comment. If you disagree with them, you just let them know that you disagree, but in a very polite way. There is something here in the NHS, everything is subtle, so no one will scream at you, no one will say unacceptable word. It's only about you and how to read between the lines. Everything is very subtle, but you can feel it. All right. After a couple of months, when people get used to you and the nurses know your name and know how hard worker, because believe me, they will know. If you're a hard worker and if you care about the patient and if you are a reliable doctor, they will know. And I think most of us by this time, we are hard worker and we are reliable doctors. So after a couple of months, when they know you and they know your name, then that's it. They are on your side and everything is just better. And please be approachable, be positive. So if they don't speak to you, just say good morning, hi lovely ladies, how you're doing. Please acknowledge everything that they're saying, everything that they're doing, even if this is their job. Acknowledge it and thank them. So if they hand you a file or something, oh, thank you, that's really nice of you. If she helped you to fix a baby's hand while you are putting the cannula, thank you for taking the time for helping me. I really appreciate it. So be appreciated, be thankful, and everyone will notice the positive change. It will come. Don't worry about it. All right. I know that sometimes some people, they feel like they are outcasted in their first days. It happens to lots of us, and it's totally acceptable. Try to engage, even if they're talking about their cats and their dogs and the stuff. Try your best to engage. Sometimes just comment on their shoes. I used to comment on their shoes. I'm obsessed with shoes. So when I see someone wear a lovely shoes, I say, "Oh, what a nice shoes! Is it comfy? Is it other?" And then that's how you start the conversation. And by now they're commenting on my hijab and my headscarves, and I tell them I bought this from TK Maxx, this from Primark, and then that's it. All right, it's hard, but it will come with time. Don't worry about it. And as I said, your work will speak for you. Sometimes this is the most powerful thing. If you work hard, then everyone will recognize it and everyone will acknowledge it. Last thing, we've been talking about all the clinical job, the management of the patients and everything, but there are some extracurricular activities that are expected from you as a registrar. So in the NHS, there is a big reliance on leadership, organizational skills, education, and mentoring. And this is all are expected from you as a registrar as well, to be involved and to show and to demonstrate some of those stuff. As I said, you need to be involved in some sort of audit or quality improvement projects. And the audit and quality improvement project doesn't have to be this huge project which take like loads of number of patients. No, even the tiniest stuff that you see in the ward and you think it needs an improvement, it can be a project. So if you notice, for example, that your SHO on the discharge letter, they are writing as symptoms, they will discharge a patient with pain, for example, or headache, rather than a diagnosis, you can do an audit on that. All right, so even the simple stuff you can do, you can take the opportunity and do them as an audit and quality improvement project. Part of the organization skills is to handle a rota. I don't advise you if you're a newcomer to handle to be a rota organizer from the beginning, because the rota is hectic and there is many gaps. So take your time, digest the system and then take the step if you want to. But you can organize a teaching rota, which is basically you have a 1 day per week, which is dedicated for teaching, and then you assign SHO to a registrar, and they can choose their topics and just make sure to remind people about the teaching day and the teaching activity. It's a very simple, it's very achievable, and it will look great for you in terms of leadership and organizational skills. There is a body system or a mentor-mentee system program, usually in most of the hospitals, so you can be involved in that, where senior trainee can guide a junior trainee, or an IMG trainee can guide another IMG trainee to guide them how to incorporate in the system and how to settle down, give them the advice. It's really a lovely thing to be done, to be honest. You can volunteer to be a local representative to your trust or to your or at your hospital, or you can work on your own agenda. For example, you may come to the UK and you have some courses that you didn't do, so you have to do some courses and some exams. So just bear in your mind that it's not all about the clinical job. You need to do some extracurricular activity. You need to work for yourself, because eventually you need all those stuff for the training application. And if you're not a trainee, you're a trust doctor, then you need it for your appraisal application as well. And it's for own development, for your own professional and for your own personal development plans, right? And for those projects, don't worry about them if you just came for 1 month or 2 months. Usually after 6 months or so, then you will know enough people and personnel, and you can be involved in them. And always ask your supervisors, because they will guide you regarding these projects and how to book them, or how to volunteer for them. My last message from today's talk: please don't panic. It's a huge move. I know everyone panics. But please don't panic. It's not as hard as you think. It's just you're not familiar with it. And my second thing is, it's a deep learning curve. You will learn a lot. You will be hit by a lot. You will have your lows and your ups. But think about it in a positive way. You would rather to face all those struggles and difficulties now, while you are a registrar and you have a supervision from the consultant, rather than having an easy and simple and short training and then face all of this difficulty when you are a consultant and there is no one there to help you or support you. So by the end of this journey, although it's very hard, but it helps you to be a good consultant, a decent consultant. Always be yourself. and be the change that you want to see. So if you are in a very rural hospital, a very in a DGH, it's white dominant and no one, for example, is dark skinned or no one is wearing hijab, well, be the change that you want to see. Show them that a dark person is a hard worker person and he's a good doctor. Show them that yes, I'm the only one who's wearing hijab in my department, but I will show you how good doctor am I. And then by the time I leave my house, everyone will think of me, of that. He will say, oh, we had a very nice doctor who was wearing a hijab and she was an excellent doctor, and then you will open the door for others. All right. And finally, this is my golden rule: if we can do it, then you can do it. Nothing is just rocket science. All right, it's just an exposure and experience. All the best for you.
Thank you very much, Mohammed Abdoun, Eiman, and Abubakr. I'm here in NHS for 5 years now, and I was impressed really by the talk, and I even get some more information and more tips and tricks to play in my daily survival in NHS. We can open now the chat, and I can unmute whoever wants to comment and whoever wants to ask a question. Feel free to ask any questions you want. Do we have any hands raised? So I just, by the time people feel scribble their questions or their comments in the chat box or unmute themselves and speak, I wanted to add just few points to what was said by all our three brilliant speakers. So the first thing, for documentation, especially, we all need to take care of our documentations. I myself had an incident with my documentation a few days ago. But one thing I learned in my first and second years of staying in NHS, I was a junior before I got to a registrar job. And I know it in the hard way when one of the consultants complained about my documentation in the ward round. So it's usually when you go in the ward round with a consultant, it's the responsibility of the junior to scribble what's going on in the ward round. And I thought it's, as far as I'm writing in a spa way, I'm safe. But I usually forgot to write what happened in the ward round, what were the discussions happening between the consultant and the parent or the child himself and the consultant and the nurses. I missed that for quite a time before knowing that I should write this. And yeah, you need to write the situation, who is at the beginning, if it is a paper system, or is it a computer-led system, whatever form you have to fill or whatever a blank paper you fill, start by who is the consultant leading the ward round. You need to write that this is ward round on the 3rd of July, 9 a.m., Dr. So-and-so. Then the situation, the SPAR, as Abubakr has profusely explained, but in part of your discussion and part of your documentation, you need to write WR, which is ward round or progress. For example, that 10 nurse is happy with the child, has no concern, or the parent has no concern, or looking at the observation, the child observations are stable, or the consultant updated the parents about the progress, the consultant explained to the parents the WheeZy plan. You don't have to go through, he said, take 6 puffs every 4 hours and then 4 puffs every 6 hours. No, you just at least mention that this discussion was made, or the consultant explained to the parents that we are not very yet sure about the diagnosis, still have more investigations to do. We are referring this child to another specialty. Write something about the discussions that has happened, especially if there are concerns from the parents or concerns, or the consultant is not very happy with how the clinical care is going on. Give a hint that there is something going on. Just don't concentrate on only writing on examination. Abdomen was soft and lax, just was clear. Cardiovascular normal heart sounds. You write the plan, you write everything, but this bit of the discussion is important. I was stung by that, but I need to, so I thought maybe it's a good thing to mention to the others. This is one thing. Maybe I will read one of the questions for.
Absolutely, and the golden rule here in the NHS: if it's not written, then it's not done. So no matter what you've done, if it's not documented, then it's not done.
Yeah, if it's not documented, it's not done. and it will come back to you really. And you don't want to lose the trust of your consultants and your teammates because of a tiny thing like that. So it's good, yeah, just to scribble and write down what, and nobody will tell you why you wrote this, but they will always ask you why you didn't write that, why you didn't document what you have said. But if you wrote like the dad was angry at the consultant, or dad wasn't happy with the treatment plan, nobody will ask you why you wrote that. Okay, so just write what happens in the handover in a clever way, but just sorry, in the word round. So one of the questions from Nipras, Eiman, are you happy to take the question?
Yeah, sure.
What is the maximum number of patients you are responsible for at night shifts?
So it depends where do you do your rotation, but usually in the DGHs, the general peds beds are from 28 to 32 beds. This is the inpatients, and then you have the pediatric assessment unit, and you can't anticipate the number of the children who come. So in the winter, it's really busy. You can see 16 patients overnight, but not all of them are sick. So some of them are just wheezer, vomiting, a bit of fever, some new RTIs, and you sort them out in 10 minutes and send them home. But it depends. So you don't have like a certain cap. We've never said like we don't have beds and we will not see any patients. No, you always have a capacity to see the patients. In the winter, it's really busy, but in the spring and in the summer, it tends to settle down.
Yeah. And as Eiman said, when you join NHS, you will learn the art of delegation, which means to make use of every single person in your team. You have a junior. I don't think in any hospital you'll be the only man standing there. Usually, if you are a registrar, usually you have a junior or two with you. So they usually take the history and do the examination for the newcomers and new patients presenting to the assessment unit. And then they will call you, tell you the history, tell you the findings and examination. And then your role will go quickly, re-see the patient and put a formulate a management plan. Again, you can give the juniors, if you have, for example, for that child, you need some bloods, you need a cannula, you need, and you think they can do it, ask them to do it, do the cannula, do the bloods, do the gas, and then you come later and you interpret the results and that kind of stuff. So it's not you are doing every single thing, and that's why you can see many patients at the same time. Mohammed Abdoun asking Eiman, do you usually call the consultant twice for a safeguarding case during the night? I mean, first to make him aware of accepting a case and then again for discussion.
So I'll tell you the trick, Mohammed. It depends on the situation itself. So a couple of weeks back, I had a call regarding a case of sexual assault, and then a sexual assault is a really sensitive case. Usually there is a forensic involvement. Usually we arrange with the gynecology team and with the surgical team. So for this case, because she was down in the A&E, I think they were sending her from a sexual assault clinic or something. So I had to call my consultant ahead just to ask him, shall we accept her in the peds ward or it should go to the gynecology ward? It's a very sensitive case. So I've called him twice for this case, to be honest. But some of the cases, like the tiny babies, the regular non-accidental injury, with time, and when I gained confidence, no, I've just called them once. After seeing the patient, examining him, making my decision, and then I call him at once, all right? So it depends on the quality of the case itself, to be honest.
Okay, thank you, man. Abubakr, are you there? I can't see all the names.
Yes, Paran, I'm here. I don't know if my video is you can see my video or not.
Okay, yeah, I can see it now. You are between you and Mohammed and Eiman, whoever feel happy to answer the questions. So Sahar is asking, hi Sahar, nice to meet you. I can't wait till you come over to the UK. So Sahar is asking, are new doctors given enough orientation time and shadowing period?
Can I take this? So when you came to the hospital, there was usually be an induction. Induction it's usually like 2 days if you came with the starting of the rota of the shift. So all the doctors, newcomers for the hospital, because you are shifting sometimes every 6 months. So every 6 months at the beginning of the new rotation, there is an induction, usually 2 days, maybe 3 days. It's a very condensed one, showing you the system, the most important thing, prescription, where is the what is the hospital, how is the hospital functioning, where is the ward. So it not will be a thorough one. If you're coming for the first job in UK, because people here changing, so they're not all the same. So they don't know if you are coming before from UK or you're coming new here. So you don't know, they will not by guarantee they will know that you're a newcomer. So if you need something special for you, you don't know, then you have to say that earlier, even from your interview, even when you came over here and you meet your senior before you start, tell them, they will understand, they know what the difference. So you don't need like to tell much. They know that, they see a lot of people coming from overseas. They don't want you to struggle. So they bring you here, they want you to work with them there, they want you to be functioning good. They know all the struggle that you can face because you are coming from a different. So yeah, you will find the induction. Some of the hospital, when you're coming, they can extend that for 2 weeks, for example. If you feel that this is a new job, you're not feeling confident, don't put yourself to, if you're coming as a registrar, don't put yourself in the on-call teams before you feeling that I'm okay with the system. Okay. I mean, you're not gonna feel that confidence yet, but still you know what to do in your on-call. So don't commit yourself into the on-call rota or to the on-call shift when you don't know anything or you're not feeling that confident. Just be open to the wherever, like your supervisor or the rota. Don't feel shy. Look, I think I'm not yet ready. I need to know this and this is still about the system here. I don't know how to sort out this one. And then you'll find the support. But don't say like, oh, I'm not gonna do like it's 3 days, and then you find yourself the next day you are the on-call registrar, and you said yes, you're gonna take that man. That mean you're already okay to do that one. So no one will excuse you later on. So if you feel that you're still hesitant about something, just ask. But the induction will depend on the hospital and depends how that hospital do. So some of the hospital, they will just take the new doctor and throw him to the on-call or to the ward the following week, which is, I think, is not fair for you, regardless whether the job needed in the hospital, if they are short or not. You will be in huge responsibilities, and you have to, they will expect you, once you've been in that role, to function well. So if you feel that you still need time, just be open to your team or to your supervisor. Say, look, I don't feel yet ready to get for that one. But again, whenever you say something, just say what you want. Just don't throw the ball to them and just sit there. Say, here, I know about this and this, but I'm struggling what I should do about this. I don't know how to function in this. And then they will sort out you quickly to get that. So my first job when I came here, they gave me 2 weeks. I went for the tertiary unit, so it was a different show. So, and they know it from them that it's different completely from where I came. So they give me 2 weeks as an induction before I went to the normal rota, like not having on calls, knowing the system, seeing how the people doing, and then I start shadowing on the night, seeing what the registrar are doing on the night before I take that responsibility. Because once you've been enrolled in that position, then they will expect you to do much.
I can echo what Abubakr have said, and adding to it, different hospitals have different rules, Sahar, and different hospitals are different in their generosity about the shadowing period. I haven't had any shadowing period because I joined as a junior. I hadn't had a single shadowing day. The induction was a very fatty and chunky 2 days of induction in which you will get given all the passwords or the links. They will take you in a tour around the hospital, show you this and this. But by the end of the end of the first 2 days, you'll find yourself that you have forgotten everything. When you go your first working day, you may feel really perplexed if you didn't get that much from the induction. And I was a junior, so I wasn't very much scared because still there is this registrar behind me and the consultants, and there were so many juniors there, so many familiar faces. I stick to, and I started asking questions. But moving on in my other trust, I found like tertiary hospital in United Unit in Leeds giving people 6 months shadowing period in a supernumerary rota, which is very generous, very good, very permissive, really, but it's not everywhere is that. So it depends really on what you ask and how you negotiate and how confident you feel. You can always tell them on the first day, I need to shadow for a while, and when I feel I'm ready, I will let you know. I don't want to be supernumerary for long because I'm not that person. I used to work independently as a registrar back home. So now just give me a few weeks and I will let you know when I'm ready. They would never make any fuss at you, I promise. They want people to be honest about when they can take that responsibility and carry the leaves. I hope this answers your question. I'm so sorry to Amal, who is had my name. I gave her my my access. Now she had a question here: how to overcome the language and accent challenge, mainly in chatting with colleagues. And who want to take the question? I'm here for 5 years. I still cannot 100% chat with my white British colleagues. Still, I miss some phrases. Still, I miss some words, but I get the most of it. So my only advice will be, if it's about the patient, always ask if you miss something. Don't act as if you have got it and then go to the patient side and you don't know what you were asked to do. If it is about the patient, always ask. And one tiny thing I want to tell about asking, I used to ask in my first few months here by saying what. If someone told me something and I didn't understand, I say what? This is just a direct translation from Arabic to English, and in back home and in Arabic, it's not true in any way. But then later I knew from my colleagues when they became friends with me that asking by what is considered rude here. So don't ask with what. Ask with sorry. Can you repeat that again? Come again. Pardon. Pardon. Oh yeah, all those are considered good, but please don't ask by saying what. It's completely unacceptable. I've done it many, many, many times before knowing this. Who want to ask to take the question of chatting in English with colleagues?
So from my own experience, to be honest, your first days or your first couple of months, you will not understand anything if you are talking outside of the medicine, usually. So the handover, I used to understand everything, but whenever they talk about something else, I really struggled with the accents, because people in Yorkshire, they have their own accent. And then with time, your ear just get trained, and then one day you will come in the morning, and then you will find yourself can understand most of the talk. So it just click like that. All right. As Mohammed Abdoun said in his advice in his talk, if you know that you will be on Scotland or Wales or something, just listen to the BBC and listen to lots of radio talks, and hopefully you will be trained to the different accents.
And another thing good about British people, really, I like it. When I was in Gulf area, sadly speaking, we used to make mockery of people who doesn't speak Arabic, but are trying to speak Arabic. Right. A different accent. We used really to, like we say, maf malum, sadiq, in a mockery way, in a sarcastic way, which I regret now. Here, English people, they never do that. They are very proud that everyone is trying to speak English, and they really feel proud of others who speak double language, because the majority of English people themselves, they only speak English because it's like the #1 language in the world, so they don't have to learn other languages. But they really feel taken out by people who can do more than a language, and because they have so many accents over the UK. They themselves are different. So they call people from London like people who are speaking the Queen language, which is the one we are used to in PPC, which is a clear English. But they have like people in Wales, people in Scotland, people in Yorkshire. Everyone has their very different accents, and sometimes they struggle to understand each other. So they really don't care what accent do you speak, as long as you speak in clear words. And if you want to make your words more clear, speak slowly. Everybody will be fine with that. So Amal, I think we are all having our times out when it comes to our white college chatting conversations. Hope this answer. So we have another question from Mustafa Ibrahim. Is there any break time for physicians, like for praying, coffee, making necessary phone calls? Mohammed, do you want to answer this one? Maybe Abubakr or Eiman?
Regarding the break, so it's saying by the JMC or all by the rules is normally you should have 20 minutes every 4 hours as a break. As what we're meaning by break is non-interruptive break. So that means you're not carrying bleep, you're not having anything with you. But in reality, usually you can't follow this rule, like you have 20-minute gap. So most of the time when there is a chance for you to get your lunch, to get your food, get it. Don't delay it. Most of the time when you're working in the normal days, so after the ward round, so sometimes after the ward round when people are finishing by 12 o'clock, and before, like if there is no urgent job, so if there is urgent job, you usually go and do it. If there is no urgent job, then this is the time to get your food quickly. And you see here, because again, it's something that you might struggle initially, because sometimes when there is a lunch break, there is a teaching time there. And because we get to use like having our food, putting everything ready, and then eat and then chat and stuff. You find people here, they're eating when they are talking, when in the teaching. Sometimes when I came first, I found it weird, because I cannot just eat while the other people are not eating in the teaching, and then there is consultant day and all the people there, and the smell of the food in the room, and you see it's not nice. But be opportunistic, so just eat with the people and don't miss that one, because not all of the time they will ask you, have you eaten or something, or go and have a break or something. So usually try to get the time when you can eat, which is usually when we're finishing from the ward round and stuff, and that there is a time, then get that time and go and eat. But as in a specific time for break and coffee, no, you have to be opportunistic. This is from my experience, and I think it's kind of generalized, like in many hospitals, all the same.
Yeah, in Leeds, for example, it's a tertiary hospital, and because the midday handover take usually like 45 minutes. So they encourage everyone to eat during the handover. Everyone bring their tea, their lunch, and just eat while doing that. And for prayer times, it depends really on if your hospital have a prayer room or no. I work in a hospital, they have a very good mosque inside the hospital, because the majority of the city were Muslims. And now I'm working in Leeds, they have a small prayer room, and it should take 5 minutes actually. Just run and try to be, you can do the wudu in time and the prayer in another time, but we usually find time to do that. Just let your team always know that you will be away. You don't need to be like, I'm going to do my prayers. You can tell them, if you're not the bleep holder, I'm going to disappear for 5 to 10 minutes, and then you come back and go and do your prayers, whatever. But yeah, you will find a chance to do them. Unless it's very much winter time. I don't want to scare people, but in winter times, you may not be able even to eat.
In the winter, the nurses, they like to have a lot of coffee breaks or tea breaks. So I consider my prayer break is one of those breaks. So I tell them, well, I'm going to have a tea break for 5 minutes, and then I run to pray and then come back, and then that's it.
Yeah. So Nifras, I'm a bit worried about cannulation. So, thank you. She said, I'm good with LPs and other pediatric procedures, but not cannulation. Is there a solution for this? I have already left the Gulf and already in the UK. Nifras, I have done my first cannula in NHS after a few failures. So don't worry, you can start doing them here. I don't know if you are coming in a junior job or a registrar job, but either way, you will learn while you go. So our advice will be, look in YouTube for videos, look in a website called Do Not Forget the Bubble. I can write it here. Do Not Forget the Bubble is one of the, I cannot find the chat to everyone here. It's a learning website. You can find it if you Google it by DFTP. they have a video about how to do successful cannulation. You can start from there, but you'll have many goals before you find yourself good or average in it. 5 years down the line, I still miss sometimes cannulation, and it doesn't have to be. You don't need to be fussy about it. Please don't let yourself down with failed cannulas. You can't get it always. You can't get it all the times. And if you are lucky, you may work in a unit when they have a vein finder or what they call bike lights. It make it easier a bit to see the veins, especially in babies who are less than 1 year old. But please don't let yourself down. You have lots of knowledge in your brain. You can use them, and someone else can cannulate that baby. You need many cannulas before you are very comfortable with them. I don't know if the other 3 speakers have any advice about cannulation.
Ron, and I think the same. I think all of the coming from Gulf. Sorry, took the advice, but I think all the same probably for all, or the same worries for all the doctors coming from the Gulf when they're not, or they de-skilled about the cannula. I think if you have done the cannulas before, like in your internship, or if you have the concept there and just you want to practice again, I think you will get that quickly. One thing when I came here to UK, because again, when you're back in Sudan or in the Gulf, you're trying to get the cannula, it isn't a big issue for the family, and all the family is just waiting you to fail to say, okay, stop doing it. I think here doing the cannula is more easier when I'm doing it in Sudan. They are more understandable. They're more kind of an accepting that the failure can happen. The small babies, they're tiny, they don't have veins. Use that word again when you're trying to get the patient on the child on ease and the family on ease. Okay, I'm going to try this. Usually, as an SSO or as a registrar, you have a certain attempt before you can escalate. So if you are an SSO, you have 2 attempts for the cannula before you escalate. So they will not allow you. Don't insist to go and put the cannula after the second one. If the nurses know that you have 3 or 4 pricks on the patient before you think that I'm going to escalate it, then that will be like against you. So you have 2 attempts as an SHO. Even as a registrar, if the consultant is around and you feel that you are struggling with this cannula, don't feel down and try, okay, no, I'm going to try again. Oh, this time I'm going to get it. No, it's not work like this. Always there is a backup. If you sometimes you call the consultant, especially if you're doing neonates, you're coming the consultant from the home at 2 o'clock in the morning to put a cannula because you failed. And nurses will be watching that. So don't insist to put a cannula if you fail. And then it is okay. If you fail, you can find a registrar with you. They don't know how the cannula. When I came here, I felt like, oh, I can't do the cannula anymore again. And then after a year in the neonate, wherever I was been in a tertiary hospital, but after a year, even on the on-call, if there is anything in that tertiary hospital, they need a cannula, they know it's difficult, and I'm on call, they call me. So it's not about that. And when I came, I was freaking out. I said, no, I'm going to not do this cannulas. I'm not doing this one, but you find that this is part of your job. Yeah, you're going to struggle initially, but if you are open and you know that all the people here are struggling and you will be good at it, then you will be good at it. So yeah, it is a big headache initially when you're coming and you see that you're lagging behind, you don't do the cannula, you know everything, but no cannula. But just learn. You have to attempt. People that are accepting that. Don't worry about the parent. They usually been understanding this issue that the cannula can fail for babies, and then if he's failed, so okay, fine, and it looks tricky, I'm gonna get some help from other from my colleagues. So yeah, don't overthink it. Just try and do it, and you'll get it in.
It also will be good if you observe your colleagues first before attempting your first cannula. Observe well, and for your first cannula, take a senior with you to help you. Usually, it needs 2 people to put the cannula, one to put for you to hold the baby and put for you the stickers and everything. And usually in your first few cannulas, take someone senior with you to help you putting it, and then you can take a junior with you. But observe well. In my first cannula, it seems like I rushed it before I observed well. So it was a big event and it turned into an incident. And I was about to pack up my suitcases and go back to Saudi Arabia. But I didn't have a visa. I had a final exit, so I couldn't do it. So it turned into a big event because I didn't watch well before I tried my first cannula. So watch well and let the senior know that you are trying the first one. They will go and support you. And start with the easy ones. Don't start with a chunky 1-year-old who have buffy hands and feet. Start with easy ones and then go up the ladder till you get there. It's always tricky. Nobody is like completely perfect with cannulas. Okay. So the question.
Hani raised his hand. Yes, Hani, he's our boss.
Oh, Hani. For whoever doesn't know Hani, feel free to contact him. We have all spoken to him before we come to the UK. He is our guidance. He is our main.
He's our godfather.
Yes, really, he's really a very helpful colleague. He's an ST7 now in Sheffield Hospital with respiratory interest. And this is a huge thank you to him before he can go in, Hani.
Assalamu alaikum.
Alaikum assalam.
Excellent presentation, Eiman, Abubakr, Mohammed. I don't think you have left anything for comments. This is probably can be printed as the golden guide for anyone who is coming to this country from somewhere overseas. Whatever you said today, we just need to print it in a book and hand it to everyone who is coming because you have excelled in doing it. Just few comments. For the handover, part of the skills is the language you use, not just for handover, if you are talking to other people also. The language we use, we have to use the language that doesn't make you look incompetent, even if things did not go the right way. This will come with practice when you watch people, when you listen to people, how they are doing things, and then you can learn how to do it. So can you see the difference between these two sentences? I failed to put in that cannula, or I couldn't do that cannula, or the third one is I didn't manage to put that cannula in. They are all the same thing. The cannula did not go into that child, but the first one and the second one will make you look like someone who failed badly in something that you are expected to do. The last one is I did not manage to put it in is, like a very neutral thing that, yes, I was expected to do it, but I didn't do it. That did not mean I'm bad, because don't use the word fail. Don't use the word I couldn't. It's just like didn't manage to. The people in this country use different ways of expressing themselves. We are usually very literal with words. That's why we struggle. Another way of doing that is in handover. Usually if you are leaving something for someone after you, so if you are the long day person leaving for the night team, or the night team leaving for the morning people, something that you should have done but you haven't done, but don't say, we are sorry, we did not see that child in ED, or we did not calculate the fluid balance for that one, can you please do that? No, it's like, we were just unable to get to that child at the end because of the busyness of the ward. We did not manage, again the same way, I did not manage to go and see the child because of that. I was unable because of the busyness of the shifts. I just couldn't get to that child. So the language makes all the difference, and this is how they talk in this country, and this is how you will be seen when you hand over, as a failure or as someone who was doing their job, but that was just outside their time or their skill or whatever. That is one thing. The other thing is, as a senior, don't let your juniors beg for assessments. I always offer. So once we go in and see, why don't we go and see that nephrotic syndrome together? Why don't you do the history? I will write for you. Okay, sometimes I hold the writing notes. I write for the SHO while they are taking history. That gives me the time to observe the case, how they are dealing with it. And at the same time, I am absorbing whatever history and everything they are doing. And I can give them better feedback at the end. And then at the end of the case, I'll say, you know what, you did very well. Why don't you send me that as a mini case? Or why don't we discuss it more a little bit and then we can do it as a CBT? That's why they love you, Eiman, and that's why they always give me always good reports on MSF, because this is how I deal with them. I don't wait for them to ask for assessments. I always offer assessments. And this is why we struggle as registrars, because consultants never offer assessments for you. And you always have to beg and chase them. So that is the second thing I wanted to comment on. I think the rest of it is just, as you all mentioned about it. I had an exceptional induction in this country. So I was left as 3 months as an extra person in the rota. This is exceptional, and I don't think it will ever happen again for anyone. I don't know, but I have been left on the rota for 3 months without having to be, you know, the responsible person. I came as a registrar in emergency department, pediatric emergency, but I have never been, you know, if you are absent, then you are just an added person. But if you are in, then you are learning. So yeah, Abubakr and Eiman has said enough about that. I'm not going to go into details, but yeah, the nurses will be watching you like a hawk as a new person. Some of them will be and some might be helpful in supporting you. Always show them the good side of you, as Imam mentioned. Be friendly, ask about their, you know, personal lives and things. And even if you think it is boring, you know, about their dogs and their cats, if you are, this is not part of our culture, just get involved in it. Get involved in it, they will like it, and they will make your life easy. Thank you, and 5 stars for the presentation.
Hani, just a tiny bit add to the nursing colleagues bit. They always love when you come and ask them about their patient. What's your opinion? What do you think? Come and tell me what's going on with your baby. How do you think he is or she is? This question changed them from hostile to nice, really. They are usually reasonable. But if you do not appreciate their opinion, I wouldn't appreciate anybody who wouldn't appreciate my opinion. Is that right? So they're just like us. So talk to them, especially in the simple cases like wheezers. Instead of going and doing a thorough review of all the history, all the notes, looking yourself at the observation, if you grab the nurse and ask her, how is the baby doing? She will tell you he's improving. He's another child now. It gives you a hint, and at the same time, she will feel better, and she will feel your recognition of her role and your recognition of how she does. You may not agree with her plans. So some of them are, because they are super senior, they are very confident in discharging patients, and they may ask you to discharge a patient from the assessment unit whom you doesn't feel happy to discharge. And instead of telling them, no, you are wrong, tell, I wish I was that confident like you, but I still feel twitchy of sending him home. I prefer to watch him for a couple of hours before I make that decision. You are doing the same thing at the end. You are keeping the patient because you don't feel like he needs to go, but you are not telling them that they are wrong. No, you are telling them they are super confident, and at the same time, you're not undermining yourself. So try to have that social attitude cleverness in dealing with them, and then they will put you high top in the rank. Are there any more questions?
There's a question in the chat, and I think Buran, Hani, or Abubakr are best people to answer it. Do you recommend to work, here's Ahmed Jibril, he's asking, do you recommend to work in DGH or tertiary hospital? In other words, if you are not training, which is better?
I work in a DGH, and then I'm now working in a tertiary hospital. Each one has its cons and pros. So DGH is good in that the quality of the patients, they are not very sick. They can be very busy, but the cases are not very complex. You'll see wheezers, you'll see bronchi, you'll see nephrotics, you will see the normal day-to-day cases that you expect to see in a child observation unit. On the other hand, in the tertiary hospital, you see complex patients with complex needs. You'll see lots of patients with trachea, with home ventilation, with a lot of intractable seizures, that kind of stuff. But on the other hand, the DGH, you will be supported by your consultant, your team, the pediatric team, but you wouldn't have that subspecialties to call them in need. And you may not have a PICU team to come with you to the resource when there is a very sick patient. This is something that will be very good, very like well approached in a tertiary hospital. When a crash call come and you are the registrar, when you go down to resource, everybody's there. You'll find yourself doing nothing actually, just with someone prescribing some medicine or like distributing roles between others, but everyone is there, the ENT, the anesthesia, the PICU who may lead it, the ED consultant, everyone. In a DGH, some of those will be there, but not everyone. On the other hand, in a DGH, it's a tiny group, it's a tiny community. So either you like it and you like them, or you hate it and you hate them. In a tertiary hospital, it's usually a big team, and you'll be very much diluted into that team. I find myself more comfortable in a tertiary hospital, but people are different and have different experiences. Maybe Hani has also worked in both. Hani, are you still there? Abubakr, you have both worked in both?
For me, I started the reverse. So I started with the tertiary hospital first and then went to the district hospital. Yeah, so the same, like as you said here, in the tertiary, you have complexity, but you are supported all the time, either by other specialties, or you're supported during the night because you'll not be the only registrar on the floor. You have other registrar that covering other specialty that they can support you during the night if you are busy, if you are having quick question that you want just like someone to guide you. So you'll be complexity, but again, supportive. When you go to the district hospital, as Eiman said, the complexity of the patient or paralysis, right? It's the complexity is less. So you're gonna see like gastroenteritis. So it depends what you like actually. Me, I started with a tertiary and went to the district, and I found it difficult when I went to the district because you want, to do that all with the patient. You want to see the outcome. So your patient admitted from the general ward, went to the respiratory, you can see that patient there, you see this progression and stuff. So again, I like it when I was on the tertiary hospital. I didn't find myself anymore in the district hospital, to be honest. In general pediatric, I just felt it's so boring, to be honest. But it all has the thing that the skills you're gonna learn. So in the district hospital, when you don't have that facilities, for example, in a tertiary hospital, when you're struggling with the cannula, you don't need to call your consultant. The anesthetist can come and help you with ultrasound. So you don't have that that problem. If the baby is very sick, you will just inform them, call consultant, because you know that there is a consultant BICU coming to you there. So when it's get bad or it's been get very difficult for you, you're not only lonely there. So there's always someone support, and that can give you some confidence that you never end up like you don't know anything. You have a pediatric emergency unit that the nurses that know about the pediatric, staffing know about the pediatric. You don't have that all that preferring. That's not good. So in either way, like if you go to the, that will be the personal preference at the end. If you start in the district hospital at the beginning, it is very low base, so you can learn stuff easy one by one. You don't be in rush to know everything because it's not that super busy usually. If you go to the tertiary, then you need to get involved with the team very quickly and to get like adapted very quickly. So either way, I think there is no I can't say like any preference to say go to the district hospital first or go to the tertiary hospital first. I think both of them you're gonna learn, and then you need to go for the tertiary hospital. But if you're kind of a person that he like slow pace, need to learn things one by one, like for example stuff like the cannulas and stuff that you need your time, there is no sick patient around, people are free to help you. This is a benefit I think from the district hospital. Or in the tertiary hospital, the dynamic of the work is high, so you need to get yourself quickly with this stuff. Like you need to learn the cannula. There is a lot of opportunities you can do that cannulas, because it will be 6-7 cannulas that they need it in the floor shop, maybe example 3-4. So you have the more attempt to do for that one. But again, you need to escalate it earlier because your registrar might be taken away from other things to do. So yeah, either way, I think at the end you will reach what you want. So yeah.
Ayat, she's asking for permission that she want to add something. Absolutely, Ayat. Unmute yourself and tell us.
I can't find her.
Abdoun is muted as well.
Are you? I have unmuted her twice, but it just come back. Give me a minute, Ayat. I will find you and unmute you.
Yes, I am here. Thank you, Bran. Thank you, Eiman, Abubakr, Hani. Very, very nice and very good tips. Really, it's for someone coming and for someone staying here. It is very helpful tips. I want to add something. Just I know it might be mentioned in this one, but try to sell yourself. For example, if you did a cannula, if you did LB, and because I noticed this from the British trainee, they mentioned if they did LB and it was very successful, they came and mentioned, especially in the handover, they hand over to you, not like the LB done and it is successful. No, they mentioned it's like a champion. It's a cannula did from the first time. It was a very difficult cannula. Also that intubation, they mentioned very clear. It was very difficult intubation, but I managed to get it from the first time. They sell you. They sell themselves. I know this is not in our not in our culture to sell ourselves because they feel it is. Initially what I feel الإنسان ده عبيط والله كنت بقول جوا قلبي كده معقولة يعني عشان عمل LB يعني بتكلم كده لكن وبكونوا it is echo during the round, during the handover, during the whole the day we are just speaking about that person did LB and it's something for me it is simple but no they put it reward from him. That's why just try to what you did something good at that day, just mention it very clear and in the right way. I did something like that. It was a difficult mom, but I tried to get it. Yes, and also one of the British trainees, I mentioned like this. Yesterday, the night was very difficult because the mom was very difficult to manage, but I got to manage. I manage her. I speak with her and she loved me now. He mentioned clear like this. You know, it is like a type of communication. The second thing, try if you are coming to the UK, try to ask about this shadowing. No one can offer you shadowing. I will, even you are came as a junior or as a senior, because I am the one I just faced this. I learned in the difficult way. When I came the first day, I am in the long day, in the induction day. I was on induction day, and the second week I was on night, and this was horrible because no one expected. You are came from background, not you are here. You are not a trainee. Started from ST1. And they are expected, even if I came to the nurse, they mentioned to me, please, can you prescribe? I can prescribe, but where is the where is the chart? She asked, she looked to me like, are you stupid? Are you stupid? I feel like she mentioned stupid in her eyes. That's why just ask about the shadowing. Even you are SHO, even you give you the road of SHO, ask about shadowing, because the SHO here, it is not the same as we did. It is not the different in the knowledge. It is the different about the system, the whole system. As Imam mentioned, Abubakr, it is something we need to learn. Every day when I go into the work, even, you know, I can learn from the medical students. They not yet graduated, I learn from them, especially the communication, how they can deal with the mom. When I went to the SHO and she's F1, I can learn from her how the tips of communication. All these tips, you just every day you are learn a lot, because it is a different system, different culture, and everything is different. And don't blame yourself. Every day I blame, no, this is wrong from myself. And at the end of the day, I realize, no, I am in learning process. I need to learn. What I can, I learn. This is what I want to add.
Lovely, very valuable points, Aya. Thank you very much. And usually, yeah, we have that culture of shakar nafsu, please. We don't we don't at all achieve or celebrate our achievements, but at least don't let yourself down by something that didn't go well. And as Hani said, even if something didn't go well, mention it in a way not to prescribe yourself as a failure or as a loser. Yeah, very confident, very valid point. Thank you, Ayat. Anybody else want to ask anything or want to contribute?
No, just only to echo, I thank you for mentioning this at some point. I think to go through everything about when to start in the NHS and your first job, it is stressful for everyone. So yeah, just ask and ask. Don't just try to figure everything by yourself, because you'll take time till you find out, all right, I'm doing the wrong things, I need to fix it. So yeah, so selling yourself, you don't know, we don't have that skills. Sometimes you do something and you know that people, you find out people are talking about that thing that you have done. For example, you said about cannula is difficult. Everyone, they know that, oh, we have done that, the cannula. Oh, for example, this is Brian have done that cannula, which is difficult, which is brilliant. And then when they was expecting you to come and say that one proudly, and then you don't mention it. So no one will say, oh, you have done that cannula. They'll just pass it on. And again, sometimes you feel if you go, so that's why I always put it back in my end, always get feedback from people. We are not learn to get feedback from our colleague. So just always ask. When I start my first job in unit, and I thought like, okay, I work in unit and know how to do with unit, and I didn't find problem with the knowledge, but how to run the show. So I was struggling with this issue. And by the end of my rotation, like my shift, and I was all in my aim that point just to survive this 6 months. I don't want anything. I don't want to learn. I don't want to do anything extra. I just want to get safe from this 6 months without any problem. And the fact that after I finish and I'm saying goodbye to the people, and by that time, you know the people, you know them, you can able to chat with them and have like a conversation. So when I was leaving, then you hear from the others, all right, oh, it doesn't look like was your first job in UK. You're doing good. But I didn't know that. I was saying, oh, thanks God, I managed safe from this one. But people how they look at you, because you just always underestimate yourself. You always being harsh to yourself. You end up like, oh, I'm not doing the great things, I'm not doing something good. But then you find out like after 6 months or 1 year that people say, oh, it doesn't look like you're the first job in the UK. Oh, well done. But yes, you can imagine if you get that feedback in your after 3 months or 4 months, and someone will say, like, oh, you're doing so brilliant, how that will affect you for the rest of. So instead of just getting there and worried about you're not doing something good, and then at the end you discover that, oh, I've done something good. So always, like, if you're doing handover, if you're doing cannula, just get feedback from your colleague. Ask if I'm done the things in the right way, or could I do it better in a better way. If you're on call, you are on call now. You're a registrar. You're doing your first lot of nights. Always get feedback. How was my night? If there is any problem that you, if there is anything that I could done better last night with this kind of patient. Even if you are worried, sometimes you go home. I mean, not me, but someone. Most of like. You go back home and you are still thinking about that patient. How did I manage him right? No, and then you just keep it to yourself. If you go next morning and ask consult, he might just tell you that, I might do the same thing. That if you don't have all the things. So yeah, that is the thing. So always get feedback from other. Always ask. And just something that I just remember with the language barrier and this communication barrier. If you don't know what they are talking about, ask, especially with the patient. Don't take it as a guarantee. If the mom or during the history they tell you something that you don't know, then take it like it's something you don't know. This something important or not something important. You didn't figure out what they are talking about. They mention you about something, anything like we went for this. But you don't know what is it, like prom, what prom? Ask. The mom asked me about respite. What's respite? Like, is it something different? Is this? So sometimes you don't know anything. And I remember one day I went to counsel one parent or one family, and I was working in Manchester, and it's multicultural, multi-accent, everything. And I went there, and it was my early few days. And I went there, and they talked to me about 5 minutes. I didn't understand any single word. I didn't know what they're talking about. I said, okay, fine, I'll come back. And I went for the nurses, and I said, look, I went for the counsel on this patient, but sorry, I couldn't understand anything. And then they were laughing. We say, okay, because this is like from this culture or from this one. So their accent, even for the English people, is different. So it's not my fault. So for me, because I'm coming from overseas, I couldn't figure out anything from what they're saying, but that was acceptable for the nurses. They laughed. They said, don't worry, you're going to get them. We're going to go. But if I didn't ask them, if I assume that everything, okay, I understand, I would just, oh, maybe they mean that one, and then you'll be in trouble. Just always ask. If you don't know anything, ask. Always tell them what is your background. Look, I'm very new here. Sorry, apology, my anything literacy about this one. Just ask, and then you'll be there.
Any more questions or comments? A tiny book from BSAPCH about your first few days in NHS will come out in few days. Let me say in few weeks, not to be very ambitious. And it will contain most of what has been said today and some more bits and pieces. Hopefully it will be a good read for majority of you. But I think the final advice from all the speakers is like, try to enjoy your journey. You will learn as you go. Don't be very worried. As long as your patients and babies are sound and safe, you don't need to worry about the rest. You will get there at the end. Thank you very much. And please, please, please fill for us the feedback forms. It will help all the speakers and it will help the association to plan the next upcoming sessions and events. Thank you very much. And at the end of this, Nasheed Al-Alam. Thank you.
Thank you, everyone.
Thank you, Brian.
Thank you, Rani, Mohammed.
نتحدى الموت عند المحل نشتري المجد بأغلى ثمن هذه الأرض لنا فليعش سوداننا علما بين الأمم يا بني السودان هذا رمزكم يحمي العبء ويحمي أرضكم.
Thank you. Everyone, feel free, please, to leave. Eiman, Mohammed, Hani, and Abubakr and myself will stay to discuss. We'll have some paperwork to do. I think we are alone now. Hani left? Oh dear. كنت عايزة يقعد والله. ما شاء الله أعتقد الفترة كانت حلوة صح؟
والله الحمد لله يعني أبو بكر وعبدون you nailed it يعني it was amazing talk صراحة.
يا سلام على التواضع، أنت ذاتك you nailed it.
الله يديكم العافيه يا جماعه، والله انا حاسس ان انا اكثر زول استفدت من الحاجه دي، يعني معلومات طيبه، الله يديكم الصحه والعافيه.
الله يديك العافية، ما قصرت. البرزنتيشن بتاعك برضو كان جميل وظريف to the point والله. أعتقد إنه الشغلانة كانت مفيدة والله. أنا تمنيت إنه يقعد عشان يورينا رأيه شنو في اللي حصل يعني الأكتيفيتي كلها. أبو بكر أنا أول مرة أسمعك بتتكلم بالمناسبة، يعني سمعت محمد بيقدم قبل كده وسمعت إيمان، لكن أول مرة يمكن أول مرة أشوفك أصلا. ما شاء الله الكلام كان كويس، أنا حبيت الإسبار والهاند أوفر والكلام ده.
شكرا.
لكن عموما الأكتيفيتي كانت ظريفة والله. إن شاء الله يكتبوا فيدباك كويس بيورونا how to proceed في الأيام الجاية. أنا ما أعرف عادة زمان أروى بتعمل بيعملوا ريبورت عن الأكتيفيتي، فما أعرف المفروض يعملوا ريبورت من السبيكرز ولا عن المودريتور ولا منه. حاجة بسيطة عن إنه يعني بس كانت كده من الساعة كده للساعة كده والدسكشن went well وما كان في كونسنس وكده. ممكن أنا أكتب أخده في الفولدرات. حاجة تانية عايزين تعلق عليها ولا نمشي؟ أنا ولدي جا في النص وسلم عليه وعليه اتحركت.
لا والله أنا رسلت لك كده رسلت لإيمان I quoted إيمان anyway. It was so good.
مصطفى ده احنا دايما بنسميه دايما خالي التغطية، يعني ما عارف باقي البيت فيه شنو، بيكون قاعد في البلاي ستيشن وفجأة بيقوم يعمل حاجات ويرجع البلاي ستيشن ما صحيح. البيت كله عارف إن أنا عندي ميتينج، بس شكله نسينا ما كلمنا ولا حاصل شنو. جا داخل فجأة داير يصلي ولا شنو، بس سلم عليه ومشى.
Yeah, it was so natural.
لكن المرة الجاية نقفل الباب.
No, so nice. أتوقع إن الأمور كانت ماشية كويس يعني.
أيوة.
عبدون ما قصرت أنت you take all the situation on your own. well done يعني to cover الحاجات اللي ممكن تكون ف good paying يعني للحياة اللي أنت عملتها. إيمان نفس الشيء يعني she covered most of the bits in the presentation يعني. يمكن أنا شلت الحاجة الصغيرة منكم فيعني الفضل لكم برضو أنت في المجهود بالنسبة لتغطية الحياة كلها يعني كانت لكم لكن يعني well done يعني زي ما أنت عبدون قلت برضو أنت استفدت إحنا برضو استفدنا من الكومنتات حقت اللي بتجي من إيمان أو منك أنت برضو بالنسبة للحياة اللي ممكن نكون عارفينها.
مشينا باس تايم، أعتقد إن دي واحدة من المؤشرات إن الشغلانة كانت مفيدة للناس يعني قدروا
أيوة.
مشينا زي أكثر من 40 دقيقة باس تايم، لكن أعتقد إنه الناس استفادت منها، فيديكم العافية إن شاء الله.
إحنا I think we finish within the time limit يعني بالنسبة لنا ممكن هو الدiscussion اللي كان زايد صح؟ يعني ممكن إحنا
البرزنتيشن خلصنا قبل 10 دقائق من وقت لكن الباقي ده كله كان discussion ومداخلات وكده which is good يعني it's a healthy discussion.
أيوة healthy discussion زي ما قلت.
صح. ممكن أنا حاولت أطول شوية في حتة يعني لأنه لقيت عبدون خلص في يمكن 25 minutes فقمت أنا حسيت إنه ممكن يكون في زمن فحتى رحت شوية في الأول بعدين حسيت إنه لا في زمن حيكون أكتر يعني لو كان للدiscussion يعني ممكن ما
حتة الإسبار والإسكاليشن مهمة و most people يعني كان question بتاعهم around الحتة دي وهي أكتر شيء worrying them it took us the right time يعني.
هي من الحاجات المهمة لنا لأن إحنا ما كنا نستعملها في السعودية، كانت معلقة everywhere لكن ما كان الناس really
use it. وما كنت get evaluated بها يعني كنت دائما لو استخدمت قلت إنه هنا you get evaluated as a registrar بالإسبار. أنا خصوصا ما قاعد في راسك 24 ساعة ما زي الديناميك بدون
ما حسيت إنه in your daily life تستعمل الإسبار. أنا بقيت إنه لما أجي أعمل conversation مع أي زول بوريه الموضوع شنو أصلاً بعد كده الباك الآخر أوريه ده أقول شنو. فحسيت إنها بقت يعني زي kind of a way of life يعني حتى في normal conversations مع الناس بتقول الإسبار يعني. فشوي الواحد بيقدر إن شاء الله يتملكها كويس. شكرا يا جماعة، نشوفكم على خير المرة الجاية إن شاء الله. أنا بشير الفيدباك ولا أنتوا كلكم أصلا عندكم أكسس للأكاديميك أوفيس فحتشوفوا الفيدباك هناك إن شاء الله.
أنا بنحب نشوف سكرين شوت في الواتساب جروب إحنا كسلانين.
ما أكثر مني طبعا. الله المستعان.
Thank you for the nice moderation. يعني amazing as usual Burhan. Thank you for your
الله
support.
يديك العافية، الله يرفع على حياتك، يديك العافية. الله في أمان الله يا شباب.
الله يديكم العافية. الله يسلمك. السلام عليكم.
بالمناسبة أنا أقفل الكلام ده كيف الريكوردينج والحاجات دي؟
لما تيجي تقفلي انت بدل ما تعملي ليف هيقوم يجيكي end the session for all. اعملي ايوه